mode to prevent interruption.
Thank you for taking your respective seats. Again, wishing you all a very good morning and a productive day. We have amongst us very eminent guest speakers to enlighten us about management of epilepsy, about which many of us are less aware.
Now, the commencement of inaugural function begins with escorting dignitaries onto the dais. We take pride in inviting our dignitaries.
For this, we now request Assistant Professor, Department of Neurology, Dr. Ashwini Hiramed ma'am, and Consultant Neurologist, Dr. Virupaksha Biradar sir, to escort the dignitaries onto the dais.
Thank you, sir. Thank you, ma'am. It's a blessed day to have such eminent people gracing this occasion. A day without prayer is a day without blessing, and a life without prayer is life without power. According to our culture, it is a tradition to start any event seeking the blessing of Almighty Vinayaka. Now, I invite Dr. Sinchana, second-year junior resident from the Department of Anesthesia, to lead us in the prayer.
मूषिकवाहन मोदकहस्ता चामरकर्णविलम्बितस्तोत्रा वामनरूप महेश्वरपुत्रा विघ्नविनायक पादनमस्ते 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 पाहि पाहि गजानना पार्वती नंदन गजानना पाहि पाहि गजानना पार्वती नंदन गजानना मूषिक वाहन गजानना मोदक प्रियने वामन रूप महेश्वर पुत्र गजानना पाहि पाहि गजानना पार्वती नंदन गजानना पाहि पाहि गजानना पार्वती नंदन गजानना चामरकर्ण गजानना विघ्न विनायक पाद नमस्ते विलंबित स्तोत्र गजानना पाहि पाहि गजानना पार्वती नंदन गजानना पाहि पाहि गजानना पार्वती नंदन गजानना पार्वती नंदन गजानना पार्वती नंदन गजानना.
Thank you, Dr. Sinchana, for the very pious prayer song. Now I request Dr. Ashwini Hiramed ma'am onto the dais to welcome the gathering.
Dignitaries on and off the dais, colleagues, and my dear students, a very good morning to one and all. It's my honor and privilege to stand here to welcome you all on this very auspicious, for me, it's auspicious because epilepsy is one of the most oldest known afflictions, yet we are lagging behind in its management and even diagnosing it. So I'm very happy to welcome you all. Firstly, I welcome our distinguished, honorable, and most poignant Pro-Chancellor Dr. Y.M. Jairat Sir, for accepting our invitation at a very short notice and presiding over the inaugural function despite his busy schedule. We welcome you, sir. Without our chief guests, who are eminent speakers and accomplished neurologists and neurosurgeons, our function would have been futile. I extend a very warm welcome to our chief guests of today, Dr. Shabri Girishan sir from MS Ramaya, Dr. Shivshankar Marjake sir from Kaneri Math Siddhagiri Hospital. On behalf of BLDDU family, we welcome you, sir. I also welcome our greatest mentor, Honorable Pro Vice Chancellor, Dr. Arun Inamdar sir, who is always a guiding light for us. And it's an honor to stage a dais with him. Thank you, sir. I extend a warm welcome to our beloved Dr. S.V. Patil sir, Dean Allied Health Sciences, to our registrar, very dynamic registrar, Dr. R.V. Kulkarni sir. Even though in physics, if they're not present here, our principal and dean, Dr. Arvind Patil sir, and our vice chancellor, sir, Dr. R.S. Mudar sir, I hope I have sent them the link. I hope they might be viewing. I invite them to our virtual ceremony. Beyond all this, I see the hall full. I'm really delighted. I welcome the dignitaries of the dais, my teachers, seniors, colleagues, IT staff, catering staff, students from here and outside. A very warm welcome to all once again. Thank you.
Thank you, ma'am, for the warm welcome. I now request Professor, Department of Medicine, Dr. M.S. Mulimani sir, to present the bouquet to our chief guest, Associate Professor of Neurosurgery, MS Ramaya Medical College, Hospital, Bangalore, Dr. Shabri Girishan sir. I also request Dr. Mulimani sir to present bouquet to Dr. Shivshankar Marjake sir, who is a consultant neurosurgeon, Siddhagiri Hospital, Research Center, Kaneri Math, Kollam.
Thank you, sir. Now I request consultant neurosurgeon and assistant professor, Department of Neurosurgery, Dr. Basavaraj Badadal sir, to present the bouquet to our Honorable Pro Chancellor BLDE, Dr. Y.M. Jayaraj sir. Thank you, sir. I request Dr. Ashwini Hiramet ma'am to present the bouquet to our Honorable Pro Vice Chancellor BLDE, Dr. Arun Inamdar sir.
Thank you, ma'am. I now request Dr. Mallappa Hogi sir, who is a consultant neurosurgeon, to present the bouquet to our beloved Dean of Allied Health Sciences, Professor of Department of Pediatrics, to Dr. S.V. Patil sir.
I request Medical Superintendent, Professor of Medicine, Dr. Rajesh Honutaki sir, to hand over the bouquet to Chairman, Professor and HOD in Department of Medicine, Dr. Sharan Badigere sir. Thank you, sir. Now I request Dr. Sharan Badigere sir to brief about the CME program.
Good morning, everybody. Dignitaries on the dais, Dr. Y.M. Jayaraj sir, our Pro Vice Chancellor, Dr. Arun Inamdar, today's chief guest, Dr. Shivshankar, and our Vice Principal, our Dean Allied Health Science, Dr. S.V. Patil, and senior faculties, my department colleagues, and other colleagues from other department, my postgraduate students, undergraduate students, and invitees. So the continuing medical education program is a part of everybody life to know the updates, recent advances, what is happening in and around the world. I remember once with interacting with our Pro Chancellor, he was telling about learn, unlearn, and relearn. Some things, after sometimes they become obsolete, we have to unlearn them. Again, sometimes emerging things happen, again we have to relearn. So this is a continuous process. So 10 days before, we conducted a CME in memory of Dr. late C.R. Bidri under guidance of Dr. R.C. Bidri on oncology. And it was an AU before the World Cancer Day. So there are international days celebrated on each of the diseases or events. Today we have on the eve of International Epilepsy Day, which is more common condition epilepsy. We think it is more common, we know everything. But there are myths, social obligations. So this continuing medical education on epilepsy with eminent speakers, it enlightens us to upgrade ourselves, to know the recent things about epilepsy. The theme is managing lives with epilepsy. We know that, we think that we can manage what is there, but there are so many things we may miss, we may overlook, we may underdiagnose or overdiagnose. So to update ourselves, we have to attend the CMEs, we have to upgrade ourselves, we have to interact, we have to be globally with global standards, we have to match the services given to the all stakeholders. The stakeholders, I mean the people, the caregivers, the patients, and we, the healthcare professionals. So I think that the topics are relevant, important, updated, and it will make us to have a feast of academic knowledge. So I request all of you to take this opportunity to relearn and learn the newer aspects to treat, give better care to the patient and also for the caregivers. So I welcome you all for this function, and I request you to attend all these sessions with and give us the feedback what we can do to the next CMEs for the best. Thank you one and all.
Thank you, sir. What we planned in the soil of contemplation, we shall reap in the harvest of action. As the new trend is eco-friendly rituals, we will officially inaugurate this ceremony with watering of plant. I request the dignitaries to come forward.
A big thanks to all the dignitaries. I invite Associate Professor of Neurosurgery, MS Ramaya Medical College, Hospital, Bangalore, Dr. Shabari Girishan sir, on the stage to deliver the inaugural speech.
Uh, Very good morning to one and all. This is a very happy occasion to me. Being a neurosurgeon, trying to help the neurology colleagues. So that is the new era. So as rightly said by the medicine professor, so there is a huge change that has happened in last decade. So in that last decade, I've seen how neurosurgery has moved away from its mundane trauma. I mean, that is the basic service that we are supposed to provide. But then gone are the days where people think neurosurgery is full of morbidity, mortality. So now things have changed to an extent that today we are here as a team with the neurology team and the physicians to trying to help them to tackle a very difficult to treat epilepsy. So on an International Epilepsy Day, which is observed every second Monday of February since 2015. So this day is celebrated mainly to share. It provides a platform to share the stories and experiences of patients, talk about epilepsy. There are various myths and misunderstandings surrounding epilepsy, saying it's not treatable. Once there is a seizure or epilepsy, it's done for life. And patients get isolated, they go for depression, and they don't really approach any sort of clinicians thinking that it's not treatable at all. So today is a day to spread the awareness that that is not the case, and it's very much treatable. They can lead a very normal life like any others, and we can definitely make inclusive into the society, and allay away the stigma surrounding the epilepsy. I hope all of us will can and achieve this particular uh, awareness and make them more inclusive, and let them share the successful stories of treating the epilepsy successfully. So I wish grand success to this program as wonderfully arranged, and thank you for the opportunity. So yeah, welcome you all.
Thank you, sir, for your inspiring words. Now let's move on to the felicitation of our chief guests, Dr. Shabari Girishan, sir, and Dr. Shivashankar Majake, sir, for which I request dignitaries on the dais to do the honors. Thank you all. I now request our respected Honorable Pro-Chancellor, Dr. Y.M. Jairaj sir, to please deliver the presidential remarks.
I request the guest of honor to speak a few words on this occasion.
Good morning, respected teachers, esteemed faculty of this prestigious institute, my alma mater, and invited faculties, friends, and all my dear students. There can be very few honor than one of the old student being invited back to his medical school as a chief guest for this academic feast. I am fortunate to be as a guest for this event. Actually, I'm not a guest because I belong to the school. I studied here from 2000 to 2006. I'm personally overwhelmed with the joy, and I thank my teachers, all the faculties, management, and organizers for giving me this honor and opportunity. We all know that it's the environment that determines the considerable part of growth and development of any child. So it's the same institute which nourished, nurtured, taught us, and brought us to this level where we can come back and give a lecture on something we learned from here from our teachers. So we're here from 2000 to 2006 learning MBBS, and fortunately all three roommates, Dr. Basaraj, who is a neurosurgeon and heading the department here, Dr. Anand Chaudhary, who was my roommate, is a neurologist, and I being a neurosurgeon, we all belong to the same school and same room, and we are here as neurosurgeons. So I really thank, and I don't know how to express my words here, so I will not talk more and limit my talk here. So as briefed by Dr. Shabri, epilepsy is one of the most devastating disease if not controlled properly with medications. And because of the newer advancements in the science and technology, a few of the diseases like epilepsy, which were usually treated by medicines and were not controlled, and patients who suffer without any other hope. So for that, epilepsy surgery is a ray of hope, and about which the department is kind enough to arrange such a CME on this eve of International Epilepsy Day. The theme is Managing Lives with Epilepsy. Quite interesting and very informative topics that have been covered here. And I feel that I would have been fortunate to learn these things when I was a student. So it's a very good opportunity for all of you to learn and know about this very rare concepts that the faculties are going to share here. And at the same time, I wish my alma mater and all of you very best. Thank you. Thank you very much.
Thank you, sir, for your very vivid and detailed remarks on the entire proceedings of the inaugural.
Chief guest of today's inaugural function, Dr. Shabri Girishan, guest of honor, Dr. Shiv Shankar, and our alumni, our Pro-Vice Chancellor, Dr. Arinam Dar sir, the Dean Faculty of Allied Sciences, Dr. Patil, Head of the Department of Medicine, Dr. Badigir, Dr. R.C. Bidri sir, and my dear colleagues, my dear students. At the outset, I congratulate the Department of Neurology for having come forward to conduct a CME on a very important topic, namely epilepsy, on an International Day of Epilepsy. When they came to invite me, instead of accepting the invitation to start with, I gave half an hour sermon to them. I don't know how they took it, because I thought that it is my duty to not to educate, but to at least inform and tell what is expected of a CME. I'm sure that they have taken it sportively. First of all, my congratulations to them. The second component, why is CME? Everything changes. from birth to death, we keep on changing. We get aged, we get degrees and so on. But only one thing doesn't change. That the one which doesn't change is continuous learning. Because we have to be continuous lifelong learners. So I cannot say that I'm a professor of a particular subject. It is only a designation that is given to me to ultimately facilitate teaching. But ultimately, by the end of the day, I'm a student. So as long as we are students, we keep learning. That's how we can update and update of latest development that takes place in a particular field of science. So in fact, we say that learning is continuous, learning is throughout life, learning is through life, and learning is for life. And when we say learning for life, we have chosen a topic today, namely epilepsy. More than the disease per se, from the point of the medicine, this particular disease has got a lot of social stigmas attached to it, a lot of myths attached to it. About 50 years back, I still remember number of instances where epilepsy was considered as a social stigma, where if a boy or a girl is supposed to have epilepsy, their marriage was very difficult. They used to be branded that unfit for life. And even in schools and colleges also, the teachers used to ultimately inform the parents that if your boy is epileptic, particularly if you have got number of seizures during classrooms, etc., they were not taken to picnics, they were not taken to excursions, they were not taken to any field studies. In other words, there was a social detachment of people who are prone for epilepsy. So more than the disease, it is the social battle that an individual has to fight. Not only the person who is suffering from or who is prone for epilepsy, but the family members also. So amongst the siblings, if one is having epilepsy, the parents ultimately have a lot of challenges ultimately to ensure that the person is educated. But thanks to the modern medicine, there are a lot of changes that have taken place in the management of epilepsy. But I have a few suggestions as an outsider. One suggestion is nowadays medicine has to be looked from a holistic integrated approach. Whether epilepsy is to be managed by neurologist, whether epilepsy is to be managed by medicine persons, or it should be managed by psychiatrist. So I feel that there is a need for an integrated holistic approach in the management of epilepsy, because though it's a neurological disorder, the neurologists are going to treat it. The social psychological aspects has to be treated by a psychiatrist, and ultimately a counselor has to be roped in order to ensure that the person will have to have inferiority complex. So I am of the opinion that more we go for what is called a very, very super specialty approach, we miss the holistic approach. I always tell that 21st century is known for one technology. This I have told a number of times to our colleagues also. That is called fusion technology, or it is called disruptive technology. How to distinguish this fusion technology, disruptive technology with that of the old technology? For the last 50 years, what we followed was known as fusion technology or fusion science and technology. We went on super specializing each of the component. First, it was only general medicine, then came neurology, then came other branches, and ultimately, even if they may come wherein anterior portion of the brain is one person, posterior portion is another person, limbic portion is other person, and so on and so forth. No doubt, specialization is required. But when you manage the patient, it's not the specialization that helps. Only for diagnosis, that the specialization helps. But for management, it is a holistic approach that ultimately comes into picture. That's why in 21st century, whether it's science and technology, whether it's engineering or medicine or biomedical engineering, the approach that is expected of is called fusion science and technology, fusion biomedical science and technology. When that being the case, there is always a need for CMEs in a holistic integrated manner. I am happy that the Department of Neurology has taken this particular venture. And in fact, I would have suggested if they were to come to me, but 1 week back, I would have made this into a national or a state level CME. When we have got guests from different places, definitely it's fit to be called as a state level, this one. But since we did not foresee it, we could just made it into an institutional ones. So henceforth, at least we'll have definitely good protocols to ensure that we'll be having the webinars or seminars or CMEs at the state level or the international level or at the national level to ensure that our students will be benefited a lot from this. In fact, about few days back when we had the CME on oncology, we had galaxy of the speakers from across India, and it was a feast to listen to all of them. And there were more than 400 online registrations who listened to that particular lectures. So because of this digital technology today, we are not only able to reach to hundreds of students who are sitting over here, but we can reach to thousands of people who can ultimately log into our particular portals. I'm extremely happy once again that on behalf of BLDE University, the Department of Neurology has taken this particular venture. I am sure the students who are sitting here will be sitting here throughout the sessions to listen to the lectures and ultimately take home a message for the betterment of science on one side, for betterment of your knowledge on the other side, and for the management of the epilepsy to serve the nation and serve the patients. Thank you very much for the opportunity.
About the importance of the CME. Now, I invite consultant neurosurgeon and assistant professor, Department of Neurosurgery, Dr. Basavaraj Badadal sir, to the dais to express his gratitude towards all gathered here and give the vote of thanks for the inaugural function. Sir, please.
Morning all. It's a wonderful event has been gathered here, and I would like to thank our Pro Chancellor Dr. Y.M. Jara sir for this invitation, and I would like to Chief Guest Dr. Severi Girish and Dr. Shiv Shankar for making this event very wonderful. And I would like to thank Dr. Arun Namdar sir, Pro VC Chancellor BLD, for accepting our invitation and arranging the occasion. And I would like to thank Dr. S.V. Patil sir, Dean Allied Health Science, and I would like to thank Dr. Badger sir, HOD of Medicine Department, and I would like to RM Hanoti sir for Medical Superintendent, accepting our invitation and making this event a grand success. I would like to other my dear teachers, my students, and attending here and enjoying this great occasion. And I hope that you definitely will enjoy the session and please listen to them. Thank you, one and all. Thank you.
Thank you, sir. I request you all to please stand for the national anthem.
Thank you all. With this, we have come to the end of this inaugural function. Now,
ನೀವು ಎದ್ದು ಓಡಾಡ್ಬೇಕಪ್ಪ ಮೈಕ್ನೋ ನೀ ಅಲ್ಲಿ
Now we move on to our scientific session. I request all the guest speakers to restrict to the given time.
We'll start with the session. We'll start with the session. I invite our first speaker of the session, consultant neurologist and epileptologist, Aster CMI, Bangalore, who is a eminent speaker, Dr. Ravish Rajiv Keni sir, to talk about approach to seizure and seizure semiology. I request the chairpersons, senior neurologist, Bhagwati Hospital, Vijayapura, Dr. S.B. Bhagwati sir, and Professor and Head of the Department of Medicine, Dr. Sharan Badige sir, to chair the session.
Good morning, all. I welcome you all for this first session of today's this Epilepsy Day conference. The first speaker is Dr. Ravish Keni from Aster Hospital, Bangalore. This will be an online session. I briefly introduce about him. He is consultant neurologist and epileptologist at Aster Hospital, Bangalore. So his key achievements are he is a American Academy of Neurology International Scholarship awarded in 2019. He has also received an outstanding reviewer certificate from Neurology India in the year 2019. So he has also been awarded Torrent Neurology Young Scholarship in the year 2017. He has, to his credit, on 32 publications in PubMed index journals and 7 book chapters. I kindly request him to take over this session and start the session.
We're talking about clinical approach to seizure and seizure semiology. So, coming to definition, a seizure is a neurological symptom that occurs due to abnormal, excessive, or synchronous neural activity in the brain. So, to simplify, seizure is a symptom, where epilepsy is a disorder or a neurological disease where patient has recurrent seizure episodes and results in consequences which can be as a result of seizures, which can be cognitive, psychological, and also affect the patient financial and social background also. So first, when it comes to seizure, we should not mimics. This Dr. Abbas will be covering in subsequent talk. So the main mimics which we encounter are syncope and pseudo seizures. So I'll be focusing on seizures per se. So when it comes to a clinical approach to a patient having epilepsy, the ILE has defined 5 axes on which we need to evaluate the patient. The first axis is the ictal phenomenology, where we describe patient symptoms like flexion, extension, clustering, etc. Then seizure type, is it a generalized seizure, the spasm, is a focal seizure, etc. Third is syndrome, which based on the history and also the seizure phenomenology, we synthesize that and we can identify the syndrome like the patient has generalized epilepsy, West syndrome, etc. Next comes the etiology, like what may be the underlying based on markers, like for example, the patient can have some skin disease, which can be neurocognitive markers, based on which we can label the patient to have tuberous sclerosis complex. And the last important thing is the impairment or disability, which is based on the WHO classification. So to simplify things, when we have a patient who is having epilepsy, we evaluate the patient clinically. The important 3 things to look at is the seizure, that is the attack history. For example, patient will have myoclonic jerks, GTCS, absence, etc. Epilepsy, where we take into account the history and also the EEG, then we classify it into primary general epilepsy, JME, temporal epilepsy, etc. And then based on this about investigation, also patient's age and clinical features, we identify a particular syndrome. For example, a patient who has juvenile epilepsy or West syndrome, etc. So this is how we can clinically approach any patient with epilepsy. Like we commonly see that most of us label the patient who has seizure disorder, but this is not the right terminology to use. So it's always better to clinically approach step by step, and then we can identify the syndrome what likely the patient may be having. So the definition of epilepsy and classification has changed in the 2017, and then currently the ILE classifies seizures into 3 main versions: focal onset seizures, generalized onset, and unknown onset. This is all based on the video EEG and also the eyewitness and the home video recording available. So generalized onset, focal onset, unknown onset, all of them have 2 components: motor onset and non-motor onset. And focal seizures can be of 2 types, where the patient has awareness retained or patient has impaired awareness. And the so-called secondary generalized seizures is being changed now to focal seizures with secondary bilateral tonic-clonic movements. So this is the old new terminology for the old entity that was the secondary generalized seizures. So the aims of basically analyzing seizure semiology is to identify the syndrome as I discussed. To simplify things, basically seizures can be either, first of all, the main history taking is for localization, which can vary as temporal seizures, temporal, or secondary is a focal seizure or generalized seizure. And the third important thing is lateralization, whether we are dealing with seizures occurring on dominant hemisphere or non-hemisphere. So these are 3 things which we look at when we take the history of the patient. So when we take the history, there are 4 important spheres which we need to take into consideration. So which will give a clue regarding what we are dealing with. The first and foremost sphere is sensorial sphere. Then second sphere is consciousness sphere, autonomic sphere, and motor sphere. So these 4 spheres basically give a very important clues regarding what the seizure the patient may be having. So coming to sensorial sphere in common terminology is known as the auras. These are the warning signs which the patient usually experiences, and patient tells us sometimes before the seizure is happening. This happens usually a few seconds to a few minutes before the onset of seizure and before the patient loses consciousness. So auras can be of various types. It can be a visual auras, which are usually can be simple, complex, or sometimes patient can only have blurry vision. The simple visual auras comprises of flashes of light. They are usually arising from the primary visual cortex. The complex visual auras comprises of people, scenes, objects, illusions. They are arise from the temporo-occipital junction, And sometimes patient can have blurry vision, which is seen in the some seizures coming from the precuneus or the posterior cingulate. Next is the auditory auras. They again can be simple and complex. Simple auditory auras includes sounds like ringing and buzzing sounds, which come from the primary auditory cortex. And complex auditory auras includes voice and music, which usually arise from the auditory association areas in the temporal-occipital cortex. And usually the lateralization is a contralateral ear. So usually the symptoms are seen contralateral side. Next is the vertiginous aura, which includes the feeling of rotation. Sometimes they can have visual symptoms and auditory symptoms. They are usually again localized in the temporoparietal junction. And lateralization is not very certain, but most commonly seen in right-sided seizures. Next is the olfactory auras, where patient has smell, or sometimes along with that there is a gustatory phenomena, mostly arise from the amygdala and also from the olfactory bulb and the insula. And usually this non-lateralizing, it's basically localization, it can be there, but lateralization is uncertain which side. It can arise from either sides. Next common aura is one of the most common auras which we encounter is the abdominal auras, the epigastric aura, where patient complains of some stomach pain. Sometimes along with that they feel nausea, they feel sometimes chest discomfort, or sometimes epigastric rattling feeling. This commonly is seen in temporal epilepsies. Also can be seen in the insula also, and they are non-lateralizing. Next is the orgasmic auras, where the patient feels sexual arousal. Along with that, they can have some sensory phenomena, which can be a vulvovaginal secretions. They are more commonly seen in women with the right temporal epilepsies. And sometimes patients can also genital auras, where they can have unpleasant sensation along with fear. They are seen in the parasagital region near the leg area. Next comes to psychic auras or emotional auras, where patients commonly seen in the neocortical temporal epilepsies, where the patients feel like deja vu phenomena or jamais vu phenomena, or sometimes they can have some complex memories which are recollected. They are non-lateralized, but localization is commonly seen in temporal neocortical epilepsies. Next sphere after the auras is the consciousness spheres. This commonly is where the patient transiently loses consciousness of a few seconds to a few minutes. It is commonly seen in the classical prototype is the absence seizures, where patient has clear spike and discharges, and also can be seen sometimes in focal epilepsies with impaired awareness, like in temporal epilepsies. And the word dilated seizure means to pass out or to interrupt or to stand still. It is a transient alteration of consciousness where patient has unresponsiveness that are not caused by motor alterations. And usually they are brief seizures lasting for more than 30 seconds in absence seizures, but sometimes can be more prolonged in patients who have focal seizures. The next, the third important sphere after the dilated is the autonomic sphere. So the primary autonomic seizures are rare. Usually patient has along with that other phenomena also. So the common autonomic seizures which we encounter is a piloerection, which is described that the patient has a goosebump. It is ipsilateral seizure focus and seen in the insula, where the patient feels like a goosebump-like phenomena during seizure onset. The next sphere is autonomous sphere. Other features can be ictal tachycardia, where the heart rate usually rises to more than 100. Bradycardia is less common. Sometimes patient can also have ictal hyperventilation, where the respiratory rate increases about 10% or more than a baseline. This is more common in patients who have pediatric temporal epilepsies, and more so in middle temporal than neocortical epilepsies. The next sphere after the autonomy is the motor sphere. Again, similar to the previous things, there can be simple or complex. Simple motor sphere just comprises of the primary motor areas where the patient has some clonic or sometimes tonic movements, and complex will be some complex repetitive movements that are usually can be considered normal, but except that for the seizure they are not appropriate. Simple motor, as I told, can be clonic seizures, which can be seen in distally in the extremity. Sometimes when the face can be inward. They occur early in the sequence, while consciousness is without in frontal epilepsies, where temporal occipital they occur later in the sequence. The simple motor can be again classified apart from the clonic, can be tonic clonic, where we say GTCS commonly, and tonic seizure, where sustained muscle contractions are seen. If the tonic seizure is if it's unilateral, it's usually contralateral to the seizure onset zone. The other simple motor seizures can be myoclonic, where patient just has brief muscle contractions lasting for less than 100 milliseconds, commonly seen from the primary motor cortex. And sometimes patient can have negative myoclonus, where patient has a drop attacks, which can be seen in parallel epilepsies. And epileptic spasms can be a cluster of these myoclonic jerks, and then it can vary from a few seconds to a more sustained tonic portion. The other simple motor seizure is the Burgess seizure, wherever the patient has a forced, unnatural, has a head deviation, eye deviation. Sometimes the whole body turns to the opposite side. This is seen early in the frontal epilepsies, where the consciousness is preserved, And as I told earlier, temporal epilepsies can be seen later on where the awareness is lost. The next seizure type after this simple motor is a complex motor seizure. It can be hypermotor, where the patient has proximal movements which are usually look like normal, but except for that, in this situation, they are not appropriate. Commonly seen in frontal epilepsy more from the ventral than the dorsal frontal regions. And along with that, sometimes the body can rotate. If the body gyration precedes the rotation, it is usually ipsilateral. If the body gyration is preceded by eye deviation and face deviation all happen together, this is contralateral. The next is a complex motor seizure, where it's apart from the hypermotor can be automotor. Is usually seen in typically in temporal epilepsies where patient has repetitive stereotype movements, which can be in the limbs, which can be in the oral apertures, and usually in the patients, this is commonly seen in temporal epilepsies. In the left temporal, they usually lose awareness, but right temporal sometimes awareness is preserved. The last complex motor seizure is a gelastic seizure, where the main component is usually laughter. It's commonly classically seen in hypothalamic hematomas, where patients characteristically have the mirthless laughter. So now after localization, important thing is lateralization. There are few signs which help in lateralization. So lateralization again is divided into 4 main entities: ipsilateral, contralateral, and dominant hemisphere, non-dominant hemisphere. So ipsilateral signs are automatisms, early head deviation, unilateral blinking, postictal nose wiping, and patient GDCS, asymmetric termination of the clonic jerk. So last jerking is usually ipsilateral in the GDCS, then it indicates it is second generalized epilepsy. So in contrast to this, contralateral signs are unilateral clonic movement, unilateral dystonia, late head or eye turning, ictal akinesis or postictal paralysis, and whole body turning along with the face and head deviation, all eye deviation, all of this is seen in contralateral. And asymmetric turning in posterior, where one limb goes into extension, is contralateral. So coming dominant hemisphere and non-dominant hemispheres, and ictal aphasia and post-ictal speech abnormality, the dysphagia is a feature of dominant hemispheres. Whereas ictal speech, bilateral automatisms with preserved consciousness, ictal smile, spitting and vomiting are commonly seen on dominant hemispheres. So this will give an idea regarding what probably we are dealing with. Just to emphasize certain clues which can further help in classifying and also for clearing the doubt regarding what we are dealing with. So first, coming to focal seizure and generalized seizures, consciousness is usually lost in generalized seizures. It can be sometimes be retained in focal seizures. Focal signs are not commonly seen in generalized seizures, whereas focal signs like eye deviation, head deviation, facial deviation, limb posturing, all these can be seen in focal seizures. And when it comes to GDCS, the last clonic jerk is ipsilateral to seizure origin in the focal seizures, whereas last clonic jerk in the GDCS is bilateral. So just to illustrate an example of a patient who had a second generalized seizure. You can see in this patient, she has the aura. She gets up. She indicates to the bystander. Then following which you can see there is the eye blinking, eye deviation to left side. The left hand is postured. These are all classical signs of a focal epilepsy. So you can see these are all contralateral. So this patient has a right temporal lesion, following which the patient has generalized seizure. You can see that the left hand, which was flexed, goes into extension. It's asymmetric tonic posturing, and then she has the full-blown GDCS. And if I forward that video, the last jerk you can see here was on the right upper limb. So this is a good example of a secondary generalized seizure. The next confusion arises is between patients who have dilated seizures, whether they are dealing with absent seizure or temporal epilepsies. The absent seizure commonly are seen in children, whereas temporal epilepsy is seen in all ages. The duration of seizures is for a few second absence, where temporal lasts for about 30 to 50 seconds. Automatisms are uncommon absence, whereas they are commonly seen in temporal epilepsies. Post-ictal confusion is absent in absence, they usually recover soon. Whereas temporal epilepsy, they have confusion. Frequency is very high, after 100 per day in absence, where temporal usually is weekly to monthly seizures, which we see. So this is a video of an absent seizure. So here she is talking, and then she stops talking. So then she recovers. The absent seizures can be of other types also, which we see, like one of them is the absences with eyelid myoclonia. You can see this child and recurrent eye bleeds and transient uprolling of eyes. So this is the absence with iridine myoclonia. And they can be also absence with axial myoclonia, like this patient who had Tassinari syndrome or the axial myoclonia absences. So you can see that a clinic when we got bilateral myoclonic jerks, the eye blinks and uprolling of eyes. So typically all these absences show a typical 3 years spike in discharge which is generalized. So apart from that, the other differentiation we need to differentiate between the patient who have temporal lobe and frontal lobe epilepsies. So temporal lobe usually seizures are less frequent, their frontal lobe are more daily. Seizure onset is slow, they are abrupt explosive, and commonly frontal lobe are more seen in sleep and temporal lobe more seen in juvenially. Automatisms are more common in temporal epilepsies, motionless stare, complex posturing. All these are less common in temporal lobe, more in frontal. And frontal lobe are mostly hypermotor, whereas temporal lobe are more hypomotor. And generalization is more common in frontal, but temporal lobe generalization is less common. Postictal aphasia and postictal confusion is more common in temporal lobe, frontal lobe they recover soon. And apart from that, the last differentiation is a mesial temporal and neocortical temporal. In mesial temporal, typically aura is epigastric aura and fear, and they have more hypomotor episodes where they are chewing automatisms and bimain automatisms. And the confusion usually is more than that. And they have contracted dystonic posturing, whereas neocortical epilepsies have more experiential aura like a deja vu or jamais vu phenomena, and they also have auditory auras. And they have early contracted dystonic posturing, whereas in mesial temporal it's a late. And in contrast to mesial temporal, the generalized seizures are much more common because of suprasigmoid spread. So I'll end my talk by showing you some classical seizure videos. So this is typically epigastric aura. You can see the patient was saying seizure, and here he has aura. This is a typical fear which is occurrences. This is the auditory aura. It's usually contractile ear plugging. This is a good example for behavior arrest. The patient was brushing here. And this is typically right hand automatisms, which are usually ipsilateral seizure onset. These are the chewing automatisms which you see. And these are the bite-bit automatism, which are more hyperkinetic, hypermotor. This is the ictal speech in the right temporal epilepsy. Where ictal vocalization is seen in dominant hemisphere. You can see the right hand is postured. Ictal singing is a rare phenomena seen commonly in non-dominant hemisphere, right temporal commonly. Ictal yawning, again a very rare phenomena seen in non-dominant hemispheres. Ictal nose wiping, usually ipsilateral. Periictal living behavior is commonly seen in right temporal. Ictal thirst and water drinking are rare phenomena. Localization usually is temporal, lateralization is not certain. Here because speech is preserved, so mostly it will be right. Left hand also is posture. Right temporal seizure. Ictal retching and vomiting is commonly seen in insular epilepsies. Ictal spitting, again non-dominant hemisphere. Ictal coughing, usually seen in temporal. This mostly the lateralization is not certain. In this patient has nose wiping in left hand, so left hand. And it's a rare phenomenon, rinse. which stands for rhythmic non-clonic hand movements. The lateral action is contralateral. Seen in temporal epilepsy, it is a contralateral to right. In this patient, mostly it is right-sided. And this is a classical example of a right ATLP. This is my presentation, and thank you all for joining, and thanks the organizing again for this opportunity. And any questions, I'm happy to answer.
Thank you, sir, for giving detailed classification, etiology, and illustration with images. I think that you have given in simple way how to approach different type of epilepsies clinically and with videographs. So I think that the undergraduates and postgraduates and the people here are very much benefited. If there are any questions from the audience, I request you to ask.
If there are no questions, I'll conclude this session. Thank you, Dr. Ravish, once again for sparing your time to be here with us for this session. Thank you.
Thank you, sir. Thank you, everyone.
I now invite Dr. Virupakshappa Biradar sir to present mementos to the chairpersons.
Thank you, sir. Our next talk is about pre-surgical evaluation with SEEG for complex drug refractory epilepsies, for which I call upon one of the eminent speaker, Associate Professor, Department of Neurosurgery, MS Ramaya Medical College, Bangalore, Dr. Shabari Girishan, sir. For this, I request chairpersons, consultant neurosurgery, Sanjeevani Hospital, Vijayapura, Dr. Yellaling Badigir, sir, and Professor, Department of Neurology, Dr. Vinay Kundargi, sir, to chair the session.
Good morning, everyone. Myself, Ellaling Badge. Today, I am very happy and privileged to introduce my teacher and today's guest lecturer, Dr. Shabari Girishan, sir. Sir is a very good and excellent teacher and very good surgeon. He's a very good person by heart. Sir has done MS General Surgery from Bangalore Medical College and MCH from prestigious CMC Vellore Medical College. After that, sir has worked in St. John's Medical College for 2 years as an assistant professor. When sir was an assistant professor, I was sir student. That time, sir has taught so many things in neurosurgery and skills and neurosurgery. And today, after that, sir has done 2 years of fellowship in prestigious Indian Institute of Medical Sciences, Delhi, in functional neurosurgery and epilepsy surgeries. And completing his fellowship, sir is presently working in MS Ramaya Medical College, Bangalore, as a assistant professor in functional and epilepsy neurosurgery. And sir is very keen in academics. Presently, sir is pursuing PhD degree in Indian Institute of Science. Thank you, sir. Welcome, sir. Welcome to the dais, sir.
Thank you for the kind introduction. At the outset, I would like to thank the organizing team for this wonderful program, and thanks for the opportunity. So I guess I would say around 60 to 70% of the crowd is students. So I guess there is something in my presentation for all of you. Basically, I would try to drive home the message more about the philosophy of epilepsy management as a team. So that's I would like to emphasize that rather than just showing the boring operative videos. I mean, that's part and parcel of our practice. But then what I want the students to remember, and many of you probably would become a neurologist and neurosurgeon, probably a good academician. So what you all need to know as to how the science has advanced and how we are here as a team with physicians successfully managing one of the most difficult to treat epilepsies. A few years ago, they're like, it was thought of as curse, for done for life, and that's one of the very dreaded myth in developing countries like ours. So I'll be covering briefly about the pre-surgical evaluation, which is one of the crux in the overall management of epilepsy. We are also known as spike chasers. We chase the spikes. So the most important thing is, before we open up the skull and go to the brain, we need to make sure that we are dealing with the right patient, right diagnosis. I'm opening up the right part of the brain, which can be resected to cure the epilepsy. So having said that, I'm not saying all patients will require surgery. All of them should go for surgery. So it's only around 30 to 40%, if I'm not wrong, that would benefit from a curative resection. But that's still quite a large number. So over a few slides, we'll like to explain how this actually happens, and how some of my patients have been literally cured of epilepsy, and also some challenges that we still face in terms of the management in eloquent cortex drug refractory epilepsy. So it's the balance between the function of the area that we are dealing with and then the seizure outcome. That critical balance is always tipped in favor of surgery or away from surgery based on what we are going to see in the pre-surgical evaluation. So it's one of the very vital aspect of the overall management of the patient. So what do we actually look for in the pre-surgical evaluation? These are some of the questions that need to be answered before we approach the patient with the solution of surgery. So does the patient really have epilepsy? What you're seeing, is it really a seizure? I guess we're going to have Dr. Abbas as a speaker, and is going to tell us the number of movements that would mimic a seizure. So a challenge in epilepsy begins from there. Is it really a seizure? And if it's a seizure, is it really epilepsy? Because not all seizures are epilepsy. That's another myth and misunderstanding, that one episode of seizure, they brand them as epilepsy. no evaluation happened, just put them on some drugs and they just go on for that. Probably it's just a provoked seizure, as simple as hypoglycemia would have induced a seizure. So it is very, very important to understand what actually the epilepsy means before we actually tell them that you are dealing with epilepsy. And once it is epilepsy, how to move on from there? Is it responding to drugs? What is the etiology in that particular patient? Is that etiology amenable for any sort of surgical management where we can resect the part of the brain and make them seizure free, just like any other disease? So these are some of the very important vital questions that needs to be answered in something known as epilepsy surgery meeting. We have epilepsy board meeting happening once a week. That's kind of a ritual for us, where every member of this epilepsy surgery team sit together, discuss the patient's problem. Dr. Ravish wonderfully showed many of the manifestations that can come in. There is pseudotemporal, to make things more complex, there is pseudofrontal, pseudotemporal, extratemporal. So what you see in MRI may not translate into the epilepsy origin. Probably the origin is way different from what you're actually seeing in MRI. And what you see in video EEG doesn't really translate into outcome. So is it really correlating? Is there a concordance? So that's another challenge that we always face. We discuss it in the meeting and say, yes, this is probably a candidate for surgical resection. If not a curative resection, can we help them with palliative options? So these are some of the questions that we need to answer before we take up a patient for surgery. So this was the old concept. There was the zonal theory, and there is a lesion in MRI, and it's very natural to presume that the brain around or from the lesion that you see in the MRI is responsible for seizure. I mean, it looks like very obvious. It sounds very obvious. Yes, there is a lesion. So that's the cause for epilepsy. So things have changed and a lot of science has gone into it. And the accepted theory is this. It's the network. It is not just a single point that is causing the seizure where you can easily go in and resect and make them seizure free. We are looking at network aspects now. There are various nodes, various zones. And being a surgeon, I can easily correlate this to a tumor, which is growing every year. So you put them on one drug, yes, the seizures are controlled. But if it doesn't, this network is going to grow. It started with temporal onset, a simple medial temporal lobe epilepsy. But then they did not gain medical attention. They went on for a second drug, third drug, fourth drug. So as the number of years passes, the network is going to grow. So when that happens, and when the opposite normal hemisphere starts throwing seizures independently, that's where my surgery is going to fail. So that should not happen. So that is the reason why the outcome following any surgery is good if diagnosed and operated, or sort of medical management is done within a period of around 5 to 6 years maximum. I would say as early as possible, this patient, if they're not responding to 2 drugs, which is the standard definition of drug refractory epilepsy, we should start thinking of evaluating them, identify the focus, and see if a surgery can help. So more than 2 drugs for more than 2 years, that is the accepted practice all around the world, to consider whether this patient is drug refractory or not. Beyond 2 years, it is unethical to keep them on the medical line of management. Provided all the options are run out, there are no other options than to manage them medically. So, but yes, fortunately, that percentage is pretty small. Most of the patients do benefit with a lot of drugs, and a lot of advances that happen in the medical management as well. So this is very important to remember, that all of you are going to deal with epileptic network and not epileptic zones. So this is the kind of workflow that we follow. So we start with routine evaluation. There is a clinical picture that we're going to consider. semiology of the patient, which Dr. Ravish beautifully described, can we start from there? You look at the semiology, can we localize that particular clinical manifestation to one lobe, frontal lobe, or is it temporal lobe? So are we dealing with the focal epilepsy or is it a generalized epilepsy? Is it generalized from the beginning? It's going to give us a lot of clue, and clinical semiology is a very, very important arm to consider for epilepsy surgery board meeting, where that feature we do consider to corroborate with other various investigations. And this is one field where the clinical examination, clinical semiology description weighs a lot in terms of management decision. So once the semiology is taken care of, the two very basic, I would say the workhorse of epilepsy workup is the video EEG and the MRI. When things are not really sure in terms of video EEG and MRI, we move on to the phase 1 evaluation. So that is the stage where we need a lot of infrastructure, a lot of fancy investigations and advanced imaging techniques. Those are all positron emission tomography, PET scan. All of you are familiar with PET scan, which has been used from years in oncology and all that, but it's making a big way into epilepsy and functional movement disorder management as well. And then the SPECT scan. I'm going to briefly describe in detail of these various tests, but all you have to remember is why are we doing such an expensive investigation is only to prevent going to phase 2 evaluation, which is an invasive investigation. If we are not going to figure out where the seizures are coming from in phase 1 evaluation, then that is the patient who can benefit with invasive investigation. Like we insert a depth electrode, confirm what we think is a seizure focus is indeed a seizure focus, which is amenable for resection. So ultimately the answer, the question to be answered is it a focus that we are dealing with? Is there a point of origin that we can pinpoint on so that surgeons can come in and resect? So the physicians and neurologists sit together to decide only that. If it's not, there are other surgical palliative surgical options also available. But obviously, the word of seizure freedom is gone. So we're not talking about seizure freedom anymore if there is no single focus. We're talking about reducing the seizure burden rather than freedom. So that's the classical workflow. And as I said, MRI brain is a workhorse in the epilepsy management. Is there a lesion in the MRI? That's the starting point. Now that, as I said, the advances are so much that we are discussing about MR negative epilepsy. That is a very big challenge for all of us. But then we are still able to cure them of epilepsy even when the MRI is negative. I have a case example to show. But then majority of the cases, fortunately, will have some lesions. Either it could be a perinatal infarct gliosis, which is a scar kind of a thing. And then there is a medial temporal lobe sclerosis. In the temporal lobe, focal cortical dysplasia, various hemispheric epilepsy syndromes, Rasmussen encephalitis, to name a few, hemimegalencephaly. There are n number of surgical causes which the MRI would show up. But all I'm driving today a message is that when an MRI done in an outside center and they come to you and the report says it's normal, please do not accept that. Please look into the features and the protocol they have followed in the MRI center. The best MRI is 3 Tesla MRI, and not just the advance of the machine itself, but then how did they acquire? That's also equally important. There's something known as epilepsy protocol to be followed. So is the MRI done in epilepsy protocol or not? That is the question all of you should ask before accepting that negative MRI report. We even published this in at our center at AIMS, where we saw that at least 60% of these negative reports done in periphery center, which is not done in epilepsy protocol, turned out to be positive when we repeated the MRI in the epilepsy protocol. What they do is to take a coronal slice perpendicular to the long axis of the hippocampus. The sampling of the hippocampus is much more in the epilepsy protocol. So the chances of picking up subtle focal cortical dysplasia, subtle changes in hippocampus is very easy when we follow that particular protocol. So do not really consider that negative report as the final thing and then write off saying this patient is MR negative, hence the surgical rule is gone. They're not responding to medication for 3 drugs and 4 drugs, so be with it. So go one step ahead, just repeat the MRI. You probably see a lesion which was not visible in the regular MRI. And the next workhorse is video EEG. I mean, I would say for any epilepsy program to be set up in an institute like this, all we need is these two set up. One is video EEG, another one is MRI, which I would say anybody can do it. Any institutes can do it. But in a right approach, it is definitely a possible step that one can take. So video EEG monitoring is a regular EEG with the video setup where the EEG and the video is synchronized. For around 24 to 48 hours, we withdraw the drugs and then observe as the seizure develops. In terms of clinical manifestation of the seizure, as the recording is going on, as the seizure unfolds right in front of your eyes. So then definitely the focus is obvious. So that's kind of electrophysiological data that you're going to get, and that you're supposed to correlate with the anatomical data you're going to see it in MRI. And if there is a good concordance between the MRI and the video EEG that you have acquired, that's it. Then the patient can be cured of surgery. So that is the huge benefit that we can get with just video EEG and MRI evaluation. And I would say around 60 to 70% of patients would fall into this category, fortunately. So that's something, I mean, those are the extra armamentarium. If you have, it's going to be great. For example, ictal SPECT, where you have to inject a radionuclide as the seizure unfolds within a fraction of 20 to 30 seconds and shift the patient quickly to the SPECT scan and then get a SPECT done. That shows beautifully where the origin is. So as I said, seizure semiology in temporal lobe epilepsy lateralizes in 78%. But if you add ictal EEG into it through the video EEG setup, your localization percentage goes to 95%. So that accurate it is, and that's how much efficient the video EEG investigation is. So now I'll just briefly touch upon the special investigation. As I said, the phase 1 evaluation, positron emission tomography scan, where you're supposed to see a hypometabolic spot, as opposed to the SPECT, which is done during the icters. PET is acquired in the interictal period, or a part of the brain which is continuously engaged in the seizure production is usually hypermetabolic because it is continuously scavenging the glucose that is coming into it. So that comes up as a hypermetabolic spot. And this is a video where the PET scan has been fused with the MRI. As our Provis is saying, there's a fusion technologies. It's amazing. So this is one of the fusion technology that we're using it in clinical day-to-day practice. As you can see on the left side, basifrontal lobe, there is a clear hypermetabolic spot coming in. PET is a functional imaging where you inject fluorodeoxy glucose and take scans and look at the metabolic activity. But when you fuse it with MRI, you're going to get a structural and functional feedback. And that's more or less enough for us to go ahead. So another investigation, as I said, is SISCOS. This is the SPECT study, which is a ictal scan. And that is a big challenge, I would say, mainly because you have to be ready with the radionuclide, which is in fact sensitive, and you have to be with the material, and the person should be available 24/7 next to the patient. As soon as you see a EEG spike, you're supposed to inject and shift the patient to the scanner. That is a big disadvantage in SPECT, and that's the reason why only a big institutes like AIMS and other places have it's not very easily replicable in other institutes. But fortunately, this is not really very important, but it has a special role in terms of MR negative epilepsy. Magnetoencephalography is another beautiful investigation which converts the electrophysiological activity picked up by the magnetic field and then puts it onto the anatomical map of MRI. So that's another beautiful investigation where electrophysiological data is combined with an anatomical data, which is vital for surgeons and epilepsy surgery team as a whole. So what you're seeing is a cluster of dipoles, magnetic dipoles in the left frontal lobe in a patient where no lesions were found in MRI. This was an MR negative epilepsy, drug refractory. We couldn't really identify any of the focus with any regular investigations. But when we did a magnetoencephalography, it did show up. And it not just shows up the focus, but also says how it propagates. So it can beautifully correlate with the seizure semiology. Patient starts having some picking movements in the hand. And as it spreads and involves his head, you can easily see that wave spreading and figure out what is the anatomical extent of pathology that is being involved. So that's the beauty of magnetoencephalography. So, but again, magnetoencephalography is available only in two places. One is AIIMS Delhi and other is NIMHANS in Bangalore. So there are various expensive investigations, a lot of advances in the phase 1 evaluation itself. But again, in India, which is a resource constrained place, one has to be very, very diligent to use the particular investigation, gather the data with the minimal investigation that is possible, and then take it up for surgery if possible. So this is what I was trying to emphasize. Anatomo-electroclinical hypothesis, sort of a workhorse where you combine all the data that you have. Starting from the clinical data, you have electrophysiological data coming up from EEG, structural data coming up from the MRI, PET scan, MEG data, and then see, is there a focus? When you combine it, I mean, we're doing research in terms of co-registration of all these images into one, where epileptogenic zone, which is an elusive zone, it's not clear in any sort of investigation. But can we look at it? Because as I say, as the definition goes, epileptogenic zone is one which after resection, the patient is seizure free. I mean, I'm supposed to open up the skull and do the surgery. I need to know epileptogenic zone before I do it, not when they come back with recurrence. So when they come back with recurrence, obviously my mapping is wrong. So to look at that epileptogenic zone, this is what we need to do. Sit together as a team. As I said, every single member of the team, which involves neuroradiologist, epileptologist, neurologist, neuropsychologist, to say what sort of global function has been affected. We should sit together and map out whether everything fits in one. And that is the time we take it up for surgery. So as I said, throughout my talk, I would like to emphasize two things. One is obviously, how are we going to choose a particular patient? How are we going to choose a particular area of the brain that needs to be resected? And how safe we are. Safety is of paramount importance. I mean, when it comes to movement disorders or epilepsy or any sort of functional neurosurgery, what we need to make sure is my patient is going to walk out as they came in, except without seizure or without any sort of movement disorder. I'm going to make sure my surgical intervention is going to take off only the seizures, not his normal day-to-day function. They're absolutely fine functioning individuals. Many of my patients were like software engineers, fully functional, but not getting controlled with 4 drugs, 5 drugs. They're the patients who we are going to deal. So safety is of utmost importance. Whenever we say, okay, brain surgery, oh my God, the life is done. I'm going to have a lot of deficits. I'm not going to move my leg and hand and things like that. So everything to be make sure that we going to give them a seizure freedom without causing any more harm. This is the workhorse. If we focus correctly on this one particular function of AEC hypothesis, we can make sure all of that. So how do we get into sort of decision? So epilepsy surgery board meeting, as I said, has a lot of team members, and each member need to make sure this algorithm is followed. this is the sort of algorithm that we follow. And MRI is just put on top for the convenience. It can be even video EEG. But is there a focal lesion on MRI? So because MR negative drug refractory epilepsy is in itself is a big challenge. So if there is a lesion, then we look at the video EEG. Is it co-localizing with MRI? Is it amenable for resection? Is there an overlap with eloquent areas, as I said? Is the hand areas of the patient is involved? Is the leg areas involved? Because once I resect the hand area, he's going to be hemiplegic or he's going to be hand paresis. So you're taking off the seizure and you're giving him paralysis. So just to make sure that we need to figure out how extensive it is in terms of involvement. That's where the invasive investigation is going to help. So this is an algorithm to point out where SEG stands in the decision algorithm that we are going to follow. So I have two case vignettes to show how the seizure origin was overlapping with hand functional area. That's sort of a very highly eloquent, especially if as a professional, we are supposed to give them seizure freedom without affecting the hand power. And then on the other side, you have a whole lot of phase 1 evaluation being done because MRI did not pick up any lesion. MRI is absolutely normal. But my epileptologist is telling me, there is a focus. Dr. Shri, you need to look into it. There is a focus. Video EEG is done. There is focus. There is a spike coming from just one single area. But electrophysiology, I would say the spatial resolution, the sampling of the brain is around 2 to 3 centimeters. So how extensive it is, that I need anatomical data. I need to be 100% sure that when I go in and resect, patient should have benefit out of it without having any risk of deficits. That's when we both sit together and go through other investigations, as I said, from the phase 1 evaluation. Does the PET tells me that it's indeed a focal onset. That's when, again, the invasive investigation is going to help us. We're going to put in the electrodes into the depth of the brain and make sure to pick up a focal onset of epilepsy. And then I say, then I'm happy when my epileptologist is happy. Yes, there is a focus, let us resect. So that is the level of safety precaution that we are taking to this day using all the advances that has happened in the field of medical science and technology. So, and if there is no focus, we still have the answers. For example, if there are palliative options, there is no focus, it's bilateral, both the hemispheres are involved, then we can help them with vagal nerve stimulations and deep brain stimulation. Those are all palliative options where once a day seizure frequency can be converted into once in 6 months or once in a year kind of seizure frequency where the quality of life can be made better. If not, we are curing, at least we are reducing the burden to the family or the caretaker to an extent they can lead a near normal life. So now coming to the crux of the today's topic, SEG. SEG is stereo electroencephalography, where we are going to record the electrophysiological activity using these depth electrodes. These electrodes are just 0.8 millimeter in diameter. Okay, that will be put in through a hole which is only around 2.5 millimeter. So it's a sub-centimeter holes that we're doing it today to insert the depth electrode under stereotactic guidance. So what are these stereotactic guidance? Basically, we sample the different areas of the brain. I mean, you saw the AEC hypothesis. There is a suspicion where deep parietal lobe or deep frontal lobe, there is a focus, which is deep, way deep. To resect that, I will have to go through the normal brain and remove the abnormal part of the brain and come out. And I need to make sure that particular trajectory is maintained. That is confirmed by this particular investigation where it's going to tell us which part of the brain that can be resected. And what are the ways of doing it? There is stereotactic way, all are stereotactic. For example, some is frame-based. That's the workhorse of any functional neurosurgeon, where we fit in a bulky frame around the head and then have a stereotactic coordinates like northeast, west, south, whatever coordinates that we have for other navigation. Here we get XYZ navigational coordinates, stereotactic coordinates. We put in onto the frame and the center of the arc is going to take me to the target that is frame based. The same philosophy can be done without the frame, that is the navigational guidance platform and the robotic platform. So all these are possible to this day. So the next few cases, I'll put in everything in terms of the workflow, in terms of the pre-surgical evaluation, and show how some of my patients have been benefited in terms of the evaluation and surgical management. This is an 18-year-old boy who presented to us with right Rolandic focal drug refractory epilepsy. Duration of epilepsy was 7 years before he came to us. Frequency initially was once in 6 months, and the time he presented to us, he had 10 episodes per day, in spite of multiple drugs. He is a very functioning individual, a nursing student who came to us, and after going all around the places, multiple drugs have been tried and failed. And he had two semiology. One is just a form of palpitation, and next is the palpitation followed by deviation of head to the right, and with a focal motor seizure involving his left upper limb. That was clinched by my neurologist and said, hey, listen, there is a focus. There is a focal onset of epilepsy. Yes, he is drug refractory, but it is worthwhile evaluating him for surgery. So when we did that, you can see here, observe his left upper limb. He has the movement of the head to the left, and then he starts having a left focal motor seizure involving his left upper limb. There's a tonic lung seizure. So at this time, we had only withdrawn just one drug, but if we had withdrawn all 3 drugs that he was on, he would have gone in for a generalized seizure. So this was enough for us to clinch that there is an onset. If you can see the 3rd row, there is onset in the frontotemporal leads. So that gave us the confidence to move on. And when we looked at the MRI, you all can make out a small white speck, small white spot in the parietal lobe, not in the motor area where one would expect because of the semiology. It was in the parietal lobe. So when we looked at the PET scan, this is again the fusion scan with MRI and the CT and the PET scan has been fused, where you can see that the hypermetabolism is way beyond the confine of that small white speck we saw in the MRI. So it was a large area which was involving his hand area. So we are dealing with a very eloquent area. The origin of seizure is close to his hand area. When we looked at the AC hypothesis, we looked at the MRI, which is a very small spot. It's a gliosis. And the PET scan, which is involving the motor cortex, but the EEG is way anterior, somewhere in the frontotemporal, not in the parietal. So there is some sort of a discordance here. We need to make sure that this particular focus is, that is all that we are seeing. Is that the reason for his drug refractory epilepsy? What is the overall extent? How big is my resection is going to be? Should I be like 4 centimeter, 5 centimeter? Because the distance between his hand area, functional hand area, and that white spot is only 1 centimeter. So does that 1 centimeter resection, does it really give him the seizure freedom? We're not sure. That's when we decided to do SEG. So we were like fortunate to do it with a robotic setup. This was the robotic platform, stealth auto guide robotic platform, where we did the planning, we planned the trajectories, and we sampled the motor cortex, supplementary motor area, right, all eloquent cortex. So that's another emphasis that I need to make, that we are going through the eloquent cortex. Now, those are like, no way, those were banned for neurosurgeons some 10 years ago. But we are able to make invasive investigation going through such eloquent cortex only because of the technological advance that has happened in this field. So we went ahead, we inserted 5 depth electrodes. That was a stealth auto guide with automatic positioning for the trajectory. I mean, it is very charming to use a robotic setup and all that, but then what it adds is only the time. We are going to save time, because to insert 5 electrode using the frame-based setup is going to take a little more time, a little more, there are chances of human error that can creep in. So only to circumvent that, we are using the robotic setup, where 5 electrodes can be inserted within a matter of an hour, where the frame base would have taken 2 hours, 2.5 hours. And when we translate the frame coordinates onto the patient, that can, errors can creep in. Whereas the robotic setup gives us the automatic guidance trajectory, where all we have to do is to make a small stab incision, put the anchor bolt, and pass the depth electrode. So what you saw was only around a 0.8 millimeter electrode that went in. So 5 such electrodes were placed. And there's another extra layer of safety that we're adding. We fuse again with the preoperative MRI that we had planned, and then the CT scan showing the depth electrode. Just to make sure, it doesn't mean that we have planned a trajectory, the electrodes will go in the same way. No, we need to confirm that. So we are going to take the patient out into the EEG monitoring room, and he's going to be there for 5 days, and you're going to depend on the data that we have put in. So we need to make sure that we have hit the bullseye. And this is the way of make sure that we have hit the right spot before we actually get the patient out of OT and put them into the monitoring room. So this is where you can see that it's not very clear here. You can see a white spot there, which is moving up and down. Those are the electrodes which has gone through the eloquent area. So this is the 3-dimensional reconstruction to make sure that all the areas that we intend to has been sampled. And once that is done, we take them to the EEG monitoring room, where we connect them to the same apparatus which was used for video EEG, and then do the recording, which can go up to 5 to 7 days. Beyond that, there's a risk of infection. So here you can see that pink third row was actually motor cortex. So to our surprise, the electrode which went in around the focus of gliosis was not the cause for seizure. All his seizure was coming from the motor cortex, which was controlling his left hand. So now we are in a fix. SEG is saying that motor cortex is responsible for his drug refractory epilepsy. So then we went ahead and we did stimulation, and that reproduced his seizure. That is the beauty of this investigation. You can confirm and reconfirm that what you're dealing with is actually the seizure focus in question. So when we did that, there's an epilepsy manifestation that came in with stimulation. So this is the elusive epileptogenic zone that I was talking about. We put in all the data that we have. Even we mapped out, look at the size of the epileptogenic zone here, as compared to the small speck of gliosis which we saw in MRI. So now at the end of the investigation, we have this data. Obviously, I'm not going to remove such a big blob of brain from his functional areas, which is controlling his right upper limb. So what strategies do we have? So this is another beauty, that today we are in a position to maintain the patient awake throughout the surgery. Dr. Shivshankar is going to discuss about the surgical part. Briefly, just to close the loop here, to tell how we proceeded this particular patient, I'm just showing this step where we map the motor area while he's awake. This is a baseline investigation that we do, baseline examination to, See, once we establish a baseline in terms of evaluation, on the other side, we are mapping the motor cortex, where we stimulate each area of the brain that we are going to resect. Make sure that is this the area that is responsible. For us, it's just a white pinkish jelly when we open up. There is no demarcation that this is the area that is causing the hand. This is the leg, which is a leg area. So we have to map it out while the patient is awake and see if the seizure can be reproduced. And when we add another layer of safety by doing intraoperative electrocorticography. We use the electrodes, make sure those are the areas which actually we saw in the ECG or in any other pre-surgical evaluation that we did. And we add dynamic white matter stimulation. As we resect, we make sure that we are away from the functional corticospinal tract, and that we did the resection. Then we repeat the ECG, and we saw that the actual culprit was motor cortex, which continued to spike. So motor cortex is something we cannot resect and make him, hand paretic. So we have a technique, what is known as multiple subpel transection. I'm sure Dr. Shivshankar is going to talk about this. So we do multiple cuts just to make sure whatever is originated in the motor cortex just stays there without a lateral spread. So with that, his seizure freedom will be controlled. with preservation of his hand function. And that's the post-operative CT showing the resection cavity and the multiple subfield transection. So he is now 2 years follow-up, able to walk, able to do all his function. This was just taken 3 months ago. So he's doing it very well, and we are planning to even discontinue the drugs. So that was the case where we know the epileptogenic focus and we dealt with it. What if the MRI doesn't show anything? I mean, where do you start when there is no MRI? That's when the huge role of neurologist comes in, where the clinical history, video EEG, only those two are going to tell the entire team where to look for. This is one such boy where a 16-year-old boy who presented with the age of onset of 3 years, duration 12 years. Unfortunately, he went around to an extent that he gone in for epileptic encephalopathy. He lost all the milestones, he lost all the intellectual abilities by the time he came. And that's the very reason why we're having such awareness talks here, to help such patients not to lose their milestones. I mean, pediatric epilepsy is one big challenge by itself. When we don't follow the standard definition of more than 2 drugs and more than 2 years for pediatrics, never. We maximum wait for 6 months. Within 6 months, if the seizures are not controlled, we are going to put them into the pre-surgical evaluation arm for a simple reason that they are going to lose all milestones by the time we try all our drugs that is possible. Now, this patient is actually seizure-free, but then all his intellectual abilities are lost. So epileptic encephalopathy is a big challenge. And we, as an epilepsy surgery team, we constantly compete with the epileptic encephalopathy and make sure that we reach before the epileptic encephalopathy reaches. So that is a big challenge. So this patient presented with a frequency of 3 per week in spite of being on 3 drugs. And as you can see, the MMSE score is only around 20 out of 30. And this was this neuropsychological assessment record showing a drastic fall in his intellectual capabilities. Though it says mild intellectual disability, he was not fit for any normal schools. He lost all his normal, childhood because of this dreaded drug refractory epilepsy. And when we did the video EEG, so if you all remember, Dr. Ravi showed temporal lobe semiology beautifully, where you can see a hand automatism, there's a chewing movements, lip smacking movements. So that gave us the confidence, yes, this child probably we can help him. This is definitely is a focal epilepsy. MRI may be negative, but we are dealing with the focal epilepsy. As you can see, the frontotemporal area started spiking with movements in the hand. You can see the chewing movement that is happening in his perioral area. So when we did the MRI, like it was a little disappointing that every single slice of the MRI that we sampled was normal, absolutely normal MRI, no lesion seen at all. We were hoping that we would see some mesial temporal lobe sclerosis, some cortical dysplasia in the temporal lobe, but it was absolutely normal MRI. And as I said, this is how the PET contributed to our management, where as we saw electrophysiological activity in the temporal lobe, PET scan showed hypometabolism. As you can see on the opposite side, on the right side, you can see how there is hypometabolic spot compared to the contralateral side. But being left side being a dominant area, we wanted to make doubly sure again that we are going to deal with a left dominant temporal lobe. So we decided to go it with SEG electrode for a simple reason that this is MR negative in a dominant left temporal lobe. So we again sorted for the SEG electrode implantation in an MR negative patient with electrophysiological data and the PET data put in together. And we sampled all these areas. We sampled opposite side as well. Sometimes it can quickly conduct through the various commissure fibers, especially the anterior commissure, and can manifest as pseudo left temporal. So we sampled that area. That is the 3D reconstruction after the placement of electrode. And you can see the red blob there. That was the seizure onset in this particular patient. and that was the ECG recording. For the sake of time, I'm not spending too much on it, but it confirmed the origin in the left temporal lobe, and we went ahead with the resection. So we did anterior temporal lobectomy with amygdalohypocampectomy, and the biopsy came as focal cortical dysplasia type 1. So this is another example where, though there was a pathology, though the MRI was negative, if you're insistent on the clinical semiology and the video EG data, we can still help them. So MR negative is not the end of evaluation. So we can still go ahead, do the ECG and see if there is a focus and operate on them. And that patient is now follow up at 3 months, absolutely no seizure with a class 1 outcome. And he's able to attend to his daily life activity, obviously with a loss of intellectual capabilities. If we had intervened, if we had an opportunity to intervene within a matter of 2-3 years, probably he could have had his normal childhood and he would have been a normal individual in the society. That's the message that all of you should consider, that every single seizure that a patient can have, at least 10,000 neurons are lost in a single episode. I mean, that is a study proven literature that every single seizure is damaging to the brain. So obviously, do not try beyond 3-4 drugs. Try to help them in some way. At least try to evaluate them and see if they can be helped. So there's another case example where even surgeons are scared of treating it, and we are waiting on it not to intervene. Not all focus should be jumped in and operated. So this is that example where a 17-year-old boy came with a duration of 6 years with a classical presentation of right upper limb focal motor seizure. Whenever it is upper limb focal motor seizure, the area involved is again hand area. So he is absolutely normal, 3rd-year nursing student, highly functional individual, absolutely no problem, except for his violent seizure episodes that you can see that he jumps up. Hypermotor seizure, as Dr. Ravish rightly pointed out, this is a hypermotor seizure. It's really embarrassing for him. He came begging to us, please stop the seizure, I cannot bear it. He cannot attend to any of his life activity, and it's very dangerous to have such hypermotor seizure while he's walking on the road. I mean, that is a big risk than my surgeries. People ask, is there a risk of surgery? I mean, if this happens on the road, the risk to life is near 100%. One of our patients, during the evaluation, she went out and being a pillion rider, had a seizure, jumped off from the bike. She came with 3/15 GCS with a severe head injury, and we couldn't really help them. So that is a killer, not the surgery. So unfortunately, this patient, we did workup, and we found out that in the T2 fair, you can see that area of gliosis is involving the hand area. It is not posterior to the hand area in the parietal lobe as we saw in other patient. This is involving the hand area as compared to the other cases. So this is the functional MRI. There's another investigation which will definitely help to map out the hand area before the surgery itself. We can see that functional hand area is seen right next to the gliosis, which is involving it. So here is a case where hand area is involved in the gliosis. We did the ECG in the similar protocol. We saw that red blob is the hand area. That is the area which is controlling his right hand. And him being right dominant, he's definitely going to have deficits. So that is the patient we decided to wait, not to operate. So only reason why we would consider surgery in that patient is that when his life is endangered. He's on 4 drugs, but still seizures are happening only at night, not during the daytime. He's not at risk. His risk to life is far less than to risk to his limbs. This is one such case where we need to strike a balance, not jump in and operate just because there is a focus. This is a focus which is going to give him a bad weakness. So we're going to wait. It is going to progress. We all know it's going to progress. But with an accepted risk, we probably would go ahead with surgery in future. So when a pre-surgical evaluation says that this is a seizure which is not localized to one particular focus, but has bilateral involvement, then we have vagal nerve stimulation. Briefly, to touch upon this topic, we just did a role of intraoperative monitoring where we need to make sure that the electrode that has been put in on the vagus nerve is indeed a vagus nerve, because the entire seizure outcome is going to be on that. So this is a patient with the extensor spasm. The case was genetic epilepsy. So I would say when you're dealing with genetic epilepsy, that's not like end of it. You can't say we can't really help them. We can definitely help them with this palliative option like deep brain stimulation or vagal nerve stimulation. So this was the extensor spasm, very frequent, affected all the intellectual milestone. And these are the number of seizures that the child was having by the time the child presented to us. Symmetrical extensor spasm, GTC, drop attacks and whatnot. So when we saw this was the only affected child. So this was the number of medication that the child was on, 8 medications. Child was on 8 medication. And when we did the MRI, it was all, other than polymicrogyria, there was no single focus. And polymicrogyria was bilateral and symmetrically involved. Obviously, this is not the kind of brain that we would want to see in a 6-year-old child. Usually it is full and normal. That's what we see. Whereas here, if you can see, there's a diffuse atrophy bilaterally. And that naturally means that the seizure, the toll of seizure on the normal brain growth. And this is what you would see in any genetic epilepsy or any drug refractory epilepsy where there is no focus. Multiple polyspikes involving both hemispheres, so diffusely involving. And when we did a genetic workup, we did find SEN3A mutation here. So it was a proven case of genetic epilepsy with no relief from the drugs. With 8 drugs and 9 drugs, still the parents are begging us to help them out. And this is one such option where we do intraoperative monitoring. And the one way to do it is to insert endotracheal tube and look at the EMG waveform that comes out of it. But in a 6-year-old child, the endotracheal tube size with this facility was not available. So what we did was to go ahead with the vagal nerve stimulation surgery with intraoperative observation of vocal cords directly. I'll just show you what exactly we do. We dissect out the vagus nerve with a sling and you expose the vagus nerve. And then there is ansa cervicalis. That nerve is one nerve which usually confused with the vagus nerve and usually brings a bad name to vagal nerve stimulation as well. So intraoperatively, when we stimulate, we can easily see the vocal cords moving in the intraoperative bronchoscopy. On the other side, my anesthetist is giving me the feedback that it is indeed a vagus nerve that we are stimulating. So we make sure that what we're dealing is vagus nerve with the intraoperative stimulation and then put in a battery, just like any other thing. And that is the helical electrodes that goes around the vagus nerve. Very safe procedure. We don't even have to open up the brain. All we need to do is to put these helical electrodes around the vagus nerve and then let the battery do the job. So definitely the seizure burden came down, and that was the stimulatory settings where 2.5 milliamperes of current was given. With a 1-year follow-up, child is having significant seizure reduction with the seizure of once in 3 months now. From 10 episodes per day, child has come to 1 seizure in 3 to 4 months. And that was all the indications. All generalized epilepsy where there is no focus, vagal nerve stimulation definitely can bring a relief. And there are n number of publications that has come up discussing the role. And these are the various types of vagal nerve stimulation. I'm not going to detail because of the sake of time. That was the modes of venous therapy, where there's a normal mode, there is an automatic mode as well, where the tachycardia can be picked up with the device and then give the vagal nerve stimulation to help them out. So with that, I would wind up. So yes, I would say there are a number of options that are available to help the patients, and one needs to be done is to choose a right patient with the pre-surgical evaluation and give them the right option. Thank you all for the patient care.
Thank you, sir, for such vivid and an enlightening talk. I request the chairperson to present the memento to the guest speaker, Dr. Shabari Girishan, sir.
Yeah, no.
Thank you, sir. I request Dr. Bardal, sir, to present the mementos to the chairpersons.
I thank organizing committee for asking me to chair the session. From behalf of organizing committee and BLDU family, I congratulate and thank today's guest speaker, Dr. Shri Girishan, for his nice and elaborate talk on pre-surgical evaluation of resistant epilepsy. Thank you, one and all.
Thank you, sir. Now for the next session to talk about diagnosis and management of epilepsy, I invite our next presenter, consultant neurologist, Dr. Ashwini Hiramet ma'am. I request chairpersons, Senior Professor, Department of Medicine, BLDE, Dr. R.C. Bidri sir, neurologist and movement disorder specialist, Aster RV Hospital, Bangalore, Dr. M.M. Abbas sir, to chair the session. Over to you, sir.
A very good morning to all the dignitaries in the audience and my distinguished guest speaker, who is my co-chairperson. It is my privilege today to introduce Dr. Ashwini Hiramet, who happens to be one of my old students, a brilliant one, if everybody knows her today. She completed her MBBS and internship in the year 2010. Subsequently, from 2011 to 13, she did her DCH from BJ Medical College, Pune. Then went on to complete her DNB in pediatrics from Narayan Udayalaya, Bangalore. After which she did not stop. Her philosophy in life is to go on working, studying, and she seems to be a very philosophical person. She did her DM Neurology from Rajasthan, SMS Medical College, Jaipur, Rajasthan, where she earned a gold medal in neurology. Please give her a big hand. She has, to her credit, numerous publications, and she is interested in pediatric neurology as well as various other advances in epilepsy. I present to you Dr. Ashwini Hiramet for today's topic on epilepsy diagnosis and management.
Thank
Please,
you, sir.
madam.
Thank you for your kind words. Good morning. And actually, the last two speakers gave such an elaborate and vivid talk that it has made my job easier, actually. So I'm not gonna go through the same things again. Yes, epidemiology, it can present at any age, childhood till adolescence or elderly also. 5% suffer almost a single seizure at some point of time, and 70% are well controlled with drugs, and 30% are pharmacoresistant epilepsy, which Shri Girishan sir has already talked about. Yes, when a patient presents to you with seizure, what do you do first? First is ascertain that if the episodes are in fact indeed epileptic seizures or they are mimics. Again, mimics is going to be covered by Dr. Abbas sir, and or it is an imposter, as I said. These are some of the common mimics of epilepsy which we see in day to day. There's the latest ILEA classification of why do we need to know the semiology, or why do we need to know which is the seizure type? Because the entire management, the medical management depends on what kind of semiology it is. Is it a focal onset? Is it a generalized onset? Or it is unknown onset? There are different drugs which help in myoclonic epilepsy. The same drugs will not work in focal epilepsis. And some can indeed worsen myoclonic epilepsy. So knowing the semiology is very, very important. And especially in children, as Sarah said, there are many genetic epilepsies and epileptic encephalopathies. So you need to identify whether whether the entire clinical scenario fits into any of the epilepsy syndromes. Are there any genetic or metabolic causes? Again, how do you diagnose? History, and history. Witness, taking history from witness is very, very important. I always tell, like rather than doing all these investigations, you can simply take a video. Patients come and complain to me that, he's having 4 episodes per day, 5 episodes per day. Etc. Now you really don't know whether they're hysterical episodes or they're true seizures. The best thing that you would advise the attenders of the patient is that to take a simple video. Identifying new onset epilepsy versus epilepsy spasm is the first challenge. After that, because of which many of the diagnosis is missed in almost 1/3 of children. Now, common causes in the elderly are usually stroke and other degenerative process. At least 7 to 21% of patients with Alzheimer's disease have at least one unprovoked seizure during their lifetime. And 43% of patients with stroke do have recurrent seizures. There are array of tests which we have today. Sir has spoken very nicely about all the available armamentarium that we have today to diagnose epilepsy. But what do you need to look for first? Is it transient epileptic, which we call as symptomatic epilepsy? Sometimes you do not go and rush into treating first seizure. Do you need to actually treat the first seizure? There are certain conditions which cause a single seizure or transient epileptic disorders. These are the common ones, like febrile seizures in early childhood up to 6 years of age, sleep deprivation, one of the most common reasons, hypoglycemia, hyponatremia, other metabolic issues, toxins, alcohol, drug abuse, some pharmacological agents, and head injury. Again, one of the most common symptomatic seizure. That is why when a patient presents to you with first seizure, at least do some routine investigations to know whether any precipitant or trigger is involved. Get an routine. These are the investigations which you get. And if you're suspecting, if the clinical scenario indicates if there is neck rigidity, if the Kernig sign is positive, if there was fever, if there was headache, vomiting, retching, etc., you can go ahead with the lumbar puncture if you're suspecting meningitis or encephalitis, along with the fundus examination also. Now, neuroimaging, sir has again beautifully explained. Again, ideally a neuro CT or CT is not the preferred modality. MRI brain with epilepsy protocol, as sir said, with thin coronal sections, which includes the temporal sections. It is very important to get the epilepsy protocol and ideally to be reported by a neuroradiologist. CT is only useful in cases of head injury and stroke. And partial, that is the newer terminology is focal seizures, are presumed to be due to a structural lesion unless proven otherwise. Now, another test which we routinely do is EEG. Again, sir has spoken a lot, very detailed explanation about EEG, stereotactic EEG and other. And these are some basics which I'm going to tell. At least get a 40 minutes recording. It is very important. Ideally, what we tell, 20 minutes sleep record, 20 minutes awake record. And ask them to come, ask them to come in a sleep deprived state. That is very, very important. And what generally we practice is we just put electrodes and the technicians run away here and there, and we will be busy in our OPD, so we do not go and sit what is happening around them. That is actually wrong. There are many artifacts. Actually, there is a sentence. This is basically for the MBBS and the intern students and PG students over here. There's a slogan which our teachers used to tell us: always underread EEG, overread ECG. That prevents unnecessary institution of drugs in epileptic patients. Always underread EEG. And sitting in front of an EEG procedure is very important to know whether it is a muscle artifact, whether it is a electrode artifact, or if you get an EEG in an ICU setup, there are a lot of machines which are going around. So that is very, very important to observe the EEG procedure, and a 40 minutes time is ideal. Stimulation procedures have to be done. It could be hyperventilation procedures, especially which precipitate abscesses in children, complex partial seizures in children, etc. There are some classical EEG patterns, which I will not go into detail. And EEG is also helpful in differentiating non-epileptic attacks from epileptic attacks. For example, these are periodic lateralized epileptiform discharges in herpes encephalitis, which you commonly see. What is this? Anybody? Okay, there's going to be a quiz in the afternoon, but either way, this is chaotic background. You cannot actually know anything from that EEG, isn't it? There's a chaotic background. So it is hypsarrhythmia, one of the commonest patterns which we see in infantile spasms in children. There are a lot of advanced investigations we have seen in the last 1 hour. So when this is some algorithm for investigating a patient presenting with seizure. When a patient comes, eyewitness, always tell, okay, the attendants come to you in your clinic and they tell you, no, we were not there, someone else was there during that time. No, that is not the thing. You call them up and ask them, hey, have you seen the seizures? What kind of seizure was it? So asking from an eyewitness is very, very important. If diagnostic facilities are not available, obviously you'll refer and perform EEG with procedures, etc. And CT or MRI, at least in focal seizures, is a must. And first seizure, it's better to get an MRI. EEG abnormality helps identify seizures type and epilepsy syndromes in many cases. It also identifies the possible etiology of seizures, like in herpes simplex and encephalitis. Some epilepsy patients may not need treatment. Some patients presenting with even a single seizure may need to be treated. We'll see what are the risk factors for recurrent seizures. So basically, it's not a nosological entity, not one disease. It is not just unique etiology. It might be a symptom of numerous disorders, symptomatic epilepsy. Sometimes even after array of investigations, you do not get what is the cause, which we label as cryptogenic. Now, yes, that the question remains again, first seizure, whether to treat it or not to treat it. The usual risk of recurrence within 5 years is 16 to 62%. And with a single unprovoked seizure, with a normal EEG and normal MRI, it's about 40%. Abnormal imaging, abnormal EEG, family history of epilepsy definitely increases the risk. And was the seizure precipitated? If it is a precipitated seizure, that is a provoked seizure, you sometimes you don't need anti-epileptic therapy, but just remove the precipitant. When to start? Ideally, AEDs. Occurrence of 2 or more seizures after first episode, if there is especially if there is, as I said, a positive family history, abnormal neurological examination, abnormal CT findings, abnormal MRI findings, epileptiform discharges on EEG. The majority of the patients, as I said, 70% of the patients do respond to drug therapy, that is anticonvulsants. In intractable cases, like in another pharmacoresistant cases, you might need to refer to neurosurgeons. What is the aim? Seizure freedom and definitely improvement in the quality of life. As everybody said, it is not my role alone. It needs a comprehensive multidisciplinary approach. You need a lot of, you need to console them, you need to counsel them, you need to tell them. A lot of patients come to me and they tell me that, my children they're not going to school. Why? Because the warden is not allowing to stay in the hostel because he has epilepsy. That is a sorry state of affairs which we still have today. Now, ideally, drug treatment should be kept simple. Start with one anti-epileptic drug, monotherapy, start low, increase low. This is the theme. Add-on therapy sometimes is necessary if not controlled by a single anti-epileptic agent. And when you're instituting polytherapy, it does require a deep knowledge of interactions because there are the conventional older anti-epileptics are enzyme inducers. Valproate inhibits the enzymes, and some women are on OCPs. There are a lot of interactions which do take place. You should know the interactions before instituting a patient on polytherapy. These are some, these are the conventional anti-epileptic drugs, the older ones, phenobarbital, phenytoin, carbamazepine, valproate. Now, phenobarbital and phenytoin, they are the oldest and the known, and even now they're used rampantly, but they do have narrow therapeutic range when compared to the newer AEDs, which we have today, like oxcarbazepine, lamotrigine, topiramate, levetiracetam, etc. Now, how do you choose an AG? It depends on the seizure type, age, sex of the patient. As I said, if a woman is planning pregnancy, you cannot institute her on valproate. You need to see these things. Epilepsy syndrome. There are defined genetic epilepsy syndromes in children where certain drugs work and certain drugs do not. Interactions, expected adverse effects. Useful as monotherapy, best is monotherapy. Try to control seizure attacks with single drug. Drug of choice usually in focal epilepsies, what we use today is carbamazepine, oxcarbamazepine. Alternative could be valproate and levetiracetam. For generalized epilepsy, even today, unless it is a female, valproate is the best drug. Alternatives, phenobarbital, phenytoin, levetiracetam. Abscesses, I'm sorry, it is ethosuximide with valproate now. Ethosuximide was in between banned and now it is again in the market, which we have today. Myoclonic valproate is again a beautiful drug. Mixed seizure type beautiful valproate, because valproate is a broad spectrum antiepileptic which works on all the channels which precipitate all the receptors inhibiting the transmission. This is the algorithm which we generally follow. Initiate with single drug. If failure, initiate a second add-on drug. If failure, then you call it as refractory epilepsy. Then ideally it is best to refer to tertiary care center, where you there's diagnostic reevaluation. Like many times 1.5 Tesla MRI does not detect any cortical dysplasias. So at that time you do need a 3 Tesla MRI, and there is armamentarium of epilepsy surgeries which is available today. As I said, these are again the same partial focal seizures. These are the drugs of choice. These are some epilepsy syndromes in children, especially where the like simple febrile seizures, actually, you don't need anything. You just need to give clobazam as a prophylactic drug during fever episodes. Second, childhood absence syndrome, ethosuximide has come back and it is a first-line drug. Valproate is a second-line drug. Rolandic epilepsy, valproate, levetiracetam, and carbamazepine also works. West syndrome, we use steroids in case of refractory seizures, ACTH, IM or IV, prednisolone and vigabatrin. Tuberous sclerosis, again, vigabatrin is a drug of choice. Dravet syndrome, valproate, stiripentol, clobazam. Nowadays, cannabidiol, though it is not licensed in India, it is licensed in some outside Europe, etc. In the same principle holds good even in adult patients, like partial onset seizures, carbamazepine still is the best. Phenytoin, levetiracetam, generalized onset valproate still is the best. But in elderly, there are some issues there. Hypertension, they have a lot of comorbidities along with them. They have renal impairment, hepatic impairment, diabetes, hypertension. There are a lot of drugs. So at that time you need to see, are there any interactions going on? Usually the therapeutic window is very narrow in older adults. Risk of toxicity is also very high. And always, whenever you are instituting a drug, anti-epileptic drug, do sit with the family and counsel, discuss the likely and unlikely but important adverse effects of each drug's likelihood of success. Ask them to maintain a seizure calendar or a seizure diary, and what are the potential triggers or precipitants. And whenever appropriate, you monitor anti-epileptic drug levels. As I said, you should know common drug interactions. Now, how many years do you continue these medications for? Minimum of 2 years, 2 to 3 years. After which, if the patient is seizure-free, then you consider withdrawal of pharmacotherapy. It should be carried out only if the patient is satisfied that a further attack would also not ruin his employment like driving, etc. It should be performed very carefully, slowly, one drug at a time. And if possible, get anti-epileptic drug levels while you're withdrawing drugs, especially if the patient is on multiple drugs, like 4 drugs, 5 drugs, you get an anti-epileptic drug level. And then you plan to individualize when you're planning to withdraw drugs. But always tell them there is a risk of recurrence. At least 20 to 30% chances are that you might again get a seizure back. Always tell the patient. Later on, they'll come and tell you otherwise. You have not told us at all. And there's some issues with pregnant females or women who are planning pregnancy. The risk of teratogenicity is very well known with phenytoin, valproate, etc. So the drug of choice in pregnancy remains carbamazepine, levetiracetam, and lamotrigine. These are some of the doses and side effects of some of the commonly used antiepileptics which we use in day to day. You should just know the common side effects at least, like lamotrigine. Before instituting patient on oxcarbamazepine, lamotrigine, you should warn them about the rash. You should tell them if you get any rash, itching, come back. Otherwise, the patient may end up in Steven-Johnson syndrome also. In elderly patients, oxcarbazepine might cause hyponatremia, right? So you need to tell that. And along with that, you need to tell them that it does require lifestyle modifications, adequate sleep, avoidance of alcohol, stimulants, and stress reduction. It is a holistic approach, not just you just write him some prescription and send him back. No, it is not going to help. You need to tell all these things. Yes, prognosis for new onset epilepsy. As I said, 2/3 patients will remain seizure free, but 1/3 patients might have recurrence of seizures. More favorable prognosis is childhood absences and benign Rolandic epilepsy. Less favorable if you have a patient with JME or juvenile absence epilepsy or mesial temporal sclerosis, there are high chances that they might end up in having another seizure when you plan withdrawal of antiepileptics. In refractory cases, obviously you can send patient to either Shabri Girishan sir or Marjake sir. They are here with us. And along with it, there are other modalities which are there, like vagal nerve stimulation, which sir told to, and diet modification, ketogenic diet in refractory cases, and a modified Atkins diet, which includes high fat and less carbohydrate diet. Or next is there are surgical options which are available today, and the prognosis is really good. You can go into it. I mean, you can withdraw antiepileptics after surgery. Thank you.
Thank you, ma'am. I now request the chairpersons to present memento to our speaker, Dr. Ashwini Hiramat, ma'am. Thank you, sir. Now I request Dr. Mallappa Hogi, sir, to give memento to the chairperson. Thank you, sir. Now I invite our next guest speaker, consultant neurosurgeon, Siddhagiri Hospital and Research Center, Kanerimat, Kolhapur, Dr. Shiv Shankar Marjake, sir, to talk about epileptic surgery, a ray of hope in refractory seizures. I request chairpersons, consultant neurosurgeon, BLDE, Dr. Mallappa Huggi, sir, and Professor, Department of Surgery, Dr. Patil, ma'am, to chair the session. Over to you, sir. Over to you, ma'am.
Good afternoon, everyone. I would like to thank the organizing committee for giving me an opportunity to chair the session. It's a proud and privileged moment for me to introduce our own alumni, Dr. Shiv Shankar Marajekappa. He has done his MBBS from BLD, and he has scored double gold medal in MS General Surgery. He has done MS General Surgery from Government College, Surat, and he has also done his MCH in neurosurgery from a very prestigious institute, Shri Chitra Institute of Medical Science, Trivandrum. And he has also done his fellow in endoscopic brain and spine surgery. And he is having n number of presentations at both national and international level, and having a vast experience. He has conducted more than 10,000 surgeries, neurosurgery, in both brain and spine surgery. And here I present our proud alumni, Dr. Shivshankar, who is going to speak on epileptic surgery, a ray of hope in refractory epilepsy.
Good morning, respected teachers. I thank the organizers for giving me this opportunity, and it's an honor for me to be here and present this talk in front of my teachers sitting here. So after quite elaborative and brainstorming lectures in the beginning from Dr. Kenny, Dr. Shabari, and Dr. Ashwini, you have a basic knowledge about epilepsy and the concept of pre-surgical evaluation and how they are being treated medically. And now I'm here to talk upon epilepsy surgery, a ray of hope in drug-resistant epilepsy. So I would like to keep it quite simple so that it can be understood by everybody. At the same time, I will try to stick to my time and finish it in 25 minutes. So as you all know that to understand in a simple way, brain is a electrical powerhouse, and we have a lot of wires wired in, and they conduct from brain down to the whole body, and they receive the signals from whole body through the sensory tracts. So, and they work in a synchrony, and when the synchrony is broken up and we might get these seizures, that is a simple way I can make you understand. And this is how initially we treat them medically, evaluate, and when the patients are not controlled on medications, we go into the surgery. So to begin with the basic philosophy of epilepsy surgery, before I start my talk, there is something called as epileptic zone that was cleared by Dr. Shabari and previous speakers. The area of brain involved in seizure is either resected, disconnected, or ablated or stimulated in epilepsy surgery. So the concept of epileptic zone is the cornerstone for the success of epilepsy surgery. Epileptic zone refers to an area of the cortex of the brain, which is responsible for ictal onset and resection of which results in seizure freedom. So the goal here is to eliminate the seizure or significantly reduce the seizure burden per se. So I would like to begin with one of the example here, the case what we did in that center, so that it will have some interest in understanding the further topics. She was a 5-year-old female child who presented to us, and she had seizures at the age of 2 years following some acute febrile illness. And she used to have a lot of seizures per day, and it is around 20 to 30 seizures per day. And literally she was in epileptic encephalopathy. She had right hemiparesis, dysphagia, cognitive decline. She was on 4 appropriate drugs on maximum doses, and there was significant impact on the patient and the family. She was completely dependent, and every half an hour she used to have seizures, even on the maximum medications. Because of this, she had loss of school, and even for the parents, there was no daily earning because somebody was supposed to attend her. And there was completely loss of social life, and full family was stigmatized. And all these seizures were preceded by some sound. Any loud sound used to precipitate the seizures, and child used to suddenly fall. So hence they shifted from the village to a farm so that they can avoid sounds, but they could not, and child continued to have seizures. She was initially evaluated and treated local hospital with no relief, and then she was referred to a epileptologist who evaluated and selected for hemispherotomy. Way back before I joined, the parents took her to Nimans, Bangalore, and because of finance constraints, even they could not go to Bangalore because it needs a lot of pre-surgical evaluation, and they have to go and come back, go and come back. So they discontinued treatment, and they came to us in 2017. So on further evaluation with 3 Tesla MRI and tractography, this is the seizure. This is a child in the pre-op. She has this right side upper limb weakness and even hemiparesis is there. So this is a preoperative MRI where you can see that left side hemisphere is completely damaged, and that is a diffusion tensor imaging where you can see the wires of the brain. On the left side, there are loss of many cortical wires. So she underwent as blind functional hemispherotomy, and wherein we disconnect the whole hemisphere. Excuse me. So that the damaged hemisphere, which was not giving a quality life to her, but it was throwing seizures and making her disabled. And this, wherein we disconnect, we do antetemporal lobectomy and amidopectomy, then we do anterior dissection, post dissection, and we disconnect corpus calotomy, commissurotomies, so that the whole hemisphere except the basal ganglionic region is spared and the whole brain is disconnected. And this child after surgery is completely seizure free. She is off all the medications. And since she was having continuous seizures, she was not able to go to school. And even her power increased and she is back to school. Parents are working. And this completely changed the life of the patient and even the family. So the 5-year-old child who was on 4 medications with a lot of social stigma is back to school. Parents are back to work. And this is how the seizures surgery cure them actually in many cases when they are properly selected and executed. So I'd like to discuss my topics under these headings: history of epilepsy surgery, the burden and consequences of epilepsy, and what exactly is epilepsy surgery, and when to consider this epilepsy surgery, and evaluation that is well covered by Dr. Shri, and who are the team members in epilepsy surgery and evaluation of epilepsy, and what are the goals of epilepsy surgery, types of surgeries, and to begin with the history. The first surgery in India was performed in CMC Vellore by Dr. Jacob Chandy in 1952. So, however, there was a decline in epilepsy surgeries in mid-70s. Shri Chitra, the institute where I'm trained, took over the comprehensive epilepsy care in India in 1990 under our Professor K. Radhakrishnan. Now it's routinely done in many national institutes like All India Institute, CMC Vellore, Nimans, Shri Chitra, PGI, SGPGI, and few of the corporate hospitals and medical colleges. So it is estimated that at any given time in India, there will be around at least 5 million people with active epilepsy, to which every year nearly around 5 lakh patients are added. 8 to 9 million people with drug-resistant epilepsy live in India, and of these, around 1.3 to 1.5 million could be benefit from epilepsy surgery. But as you know that the surgery started in 1952, there are very few centers to cater these surgeries, and there are hardly not more than 1,000 surgeries are done per year till today. So there is enormous surgical gap that can only be minimized by developing many more epilepsy surgery centers in India. Epilepsy surgery was considered, and it is still in India, as until recently to be an expensive high technology therapy restricted to metro cities. So life with refractory epilepsy is a curse to the individuals and family with significant impact on the quality of life. Most of them have a miserable, helpless end to their life. It's harsh punishment to the individual to be alive with these refractory seizures. It's painful to listen to their horrendous stories and witness as a doctor. Epilepsy surgery is a ray of hope for most of the individuals and family members. It changes the life of individual and life of family members forever. So there's a lot of stigma attached around. Stigma of epilepsy has a major negative impact on quality of life. Additionally, people with epilepsy are more likely to be unemployed or underemployed, have lower rates of marriage, loss of school, greater social isolation. So there are significant consequences of uncontrolled seizures. Many adults, there is oral trauma, head injuries, orthopedic injuries because of falls, aspiration pneumonias, depression, loss of independence, employment issues, restriction exercise, travel, driving, and cognitive decline. And suddenly there is something called a SUDEP, sudden deaths are also known to happen. In pediatrics, intellectual epileptic discharges may cause an irritable dysfunctional cortex and possibly secondary epileptogenesis, mental retardation, psychosocial and cognitive impairment, debilitating behavioral problems and aggression. So with all these things, if you see, it was really debilitating refractory seizures. They really devastate the life. And in such cases, the epilepsy surgery is a ray of hope. Epilepsy surgery is an effective treatment for reducing or eliminating seizures in patients with medically intractable seizures, wherein surgeon removes the brain where seizures begin or stop the spread of this activity by disconnecting it from the rest of the brain. Seizures control can be expected in 60 to 80% of patients with temporal lobe epilepsy and 50 to 80% patients with extratemporal lobe epilepsy. So when to consider this epilepsy surgery? When the seizures are disabling, when medications are not controlling the seizures, when the drug side effects are severe and affect the quality of life. The best surgical technique will only be effective if applied to well-selected patients with sound indications. Success of an epilepsy surgery depends upon the early identification of the potential surgical candidate, because we have to select the proper candidate and execute the proper surgery. Here, the goals are to eliminate the seizures or significantly reduce the seizure burden, and even can reduce the dose and number of medications. The final goal of epilepsy surgery are to reduce the frequency and intensity of seizures without catastrophic complications, as well as improvement in quality of life with restoration of his or her self-confidence. The primary goal of curative surgery is for the patient to be able to lead a normal life, preferably off all antiepileptic medications. Most of the patients defer surgery when surgery is told to them. They defer because they have lack of awareness, fear, and lose the opportunity. And many patients can't afford this because of a lot of pre-op workup needs a lot of money and even surgery. And there are very few centers to cater these surgeries. So it is teamwork, and the decision making for epilepsy surgery needs a multidisciplinary approach in which different investigators involved in the program in conjunction to create an integrated picture of epileptogenesis and its impact on the patient and caregivers. The key members are epileptologist, who is a team leader, epilepsy surgeon, whose role is at the end when the seizures are not controlled and when the epileptologist evaluate the patients for surgery, neuroanaesthetist for surgeries, electroencephalographer, neuropsychologist, neuropsychiatrist, neuronurse coordinator. We need to have a good infrastructure for this, and evaluation and pre-surgical workup was very well covered by Dr. Shabari. I'm not going to into the depth of it, and semiology and everything was told by Dr. Ashwini. I'll just skip these slides. Epileptic lesions. What are the causes for seizures and what causes seizures? And most of the time, wherein we can find the MRI pictures, we see these malformations of cortical development, as cortical dysplasia and hemimegalencephaly, tumors, for example, gangliomas, DNETs, vascular malformations, example, AVMs and cavernomas, inflammatory lesions, for example, tubercular, cysticercal, granulomas, and Rasmussen's encephalitis. That's most commonly seen by pediatricians. Post-traumatic seizures, post-ischemic seizures, for example, cortical scars, gliosis, porencephalonic cyst, and hippocampal sclerosis following cerebral seizures. There are many more reasons. So what kinds of surgeries are, what types of surgery are there? The location, nature of these lesions dictate the type of surgery that will be performed. That we saw in the last slide. Surgery has main three goals: remove the area of the brain that causes seizures, that is called as resection; disrupt the nerve pathways that seizure impulses take through the brain. We cut the wires, that is called disconnection; and impact a device to treat the epilepsy, that is stimulation. We have VNS papers in your hand. And coming to resective surgery involves the resection or cutting of the brain tissue from the area of the brain that consists of epileptic focus. So as in pre-surgical evaluation, we fix that this is the area from where the seizures is coming. We just disconnect it or remove it so that the seizures will not spread to the rest of the brain. Resective procedures are performed when tests consistently point to a single specific area of the brain where the seizures begin. For example, temporal lobectomy and amygdalohippocampectomy. It is most commonly done procedure mainly for mesial temporal sclerosis, which follows febrile seizures. And occiput lobectomy, mainly pediatricians know that post hypoglycemia in children's, they have occipital glycosis and they have intractable seizures wherein we do occiput lobectomy. Cortical excisions, hemispherectomies, hemispherectomies. The goal here is to remove all the seizure focus area causing seizures without causing loss of brain function. So there are other kind of, we had resective surgeries, and this is a palliative procedures, where by definition palliative procedures only very rarely result in cessation of seizures. The main what they do here is they disrupt the nerve pathways or seizure impulses straight through the brain. That is why disconnect like corpusculotomies. And palliative procedures are performed when seizure focus cannot be determined or it overlaps the brain areas of critical for movement. That is eloquent areas like speech, vision, and limb areas, wherein we just can't cut them and give the deficit. In those cases, we do these palliative procedures. These surgeries may prevent the occurrence of particular morbid type of seizures, such as drop attacks, mainly in LGS, wherein patients have a seizure and they fall, and they have multiple injuries, head injuries, fractures, and everything, or they lessen the frequency and severity of seizures. Examples of palliative surgeries include some of the cases of disconnective procedures, including corpusculotomies and vagal nerve stimulation, that is VNS. Coming to the temporal lobectomy and amygdalohippocampectomy, this is the most common type of surgery. Is this we call it as ATLAH. Seizures usually arise in the hippocampus, and although they may arise from the amygdala and parahippocampal gyrus, wherein we remove a part of anterior temporal lobe. It depends on the right side and left side. Left side is eloquent. We remove less of the anterior temporal lobe, along with majority of the amygdala, uncus, hippocampus, parahippocampal gyrus, back to the level of collicular plate. There are now specified amygdalohippocampectomy being done now. And a temporal lobectomy leads to significant reduction or complete seizure control in about almost 70 to 80% of the time. So this was a case that we did. He was a 13-year-old male boy, had his first seizures at the age of 6. It was complex partial seizures with no generalization. He was on 4 anti-seizure medications. Frequency was around 10 per month, and MRI showed right medial temporal sclerosis. He underwent a right antetemporal lobectomy and amygdalohippocapectomy. And post of 5 years, he is off all the anti-seizure medications, and he has cleared his 10th standard with 90% marks, which was affecting his schooling in his pre-surgical days. He was not able to go to the school because of having seizures, and he had even the impact was there on his schooling because he was, if he misses, he will have seizures, and there are even side effects from the medications also, for which they deferred surgery because they were offered surgery multiple times. They went to the Nimans, Bangalore, where these procedures were done, and that was the nearest place for him to undergo surgery. But they deferred, fearing for the surgery, and they continued for almost halfway through his schooling days. And at the end, we offered surgery, and he underwent, and he is completely free from seizures and free from medications now, and he is doing very good in his school. So coming to the other kinds of surgeries, that corpusculotomy. You know that corpus callosum is a band of nerve fibers which connect both the cerebral hemispheres. It is in the center, and corpus callosum is usually reserved for the people with severe generalized epilepsy, wherein seizure activity is in both the hemispheres, and you cannot offer any resective surgeries. So, who subject to drop attacks, and most of the patients, they have sudden drops, they fall down, they have injuries, and this continues along with the seizures. They are most commonly seen in setting of Lennox-Gastaut syndrome, that is LGS, a severe symptomatic generalized epilepsy syndrome with multiple seizure types. These seizures are extremely injurious because of their rapid onset and often produce multiple injuries over a period of time due to unprotected falls. So this child was one of the nephew of our own Dr. Sweta. He was a 10-year-old male child with LGS. He had a seizure from the 5th day of his life. Stopped medications at the age of 6 months by cultural misbelief by a Baba. Seizures worsened. They increased to 15-20 per day, triggered by loud noise, and had multiple times long bone fractures and even head injuries. So EEG and MRI revealed bihemispheric damage, and here he underwent corpusculotomy, wherein this involved the splitting of the main connection pathway between both the cerebral hemispheres, that is corpus callosum. And this corpusculotomy prevents the spread of generalized seizures from one side of the brain to the other side by disconnecting the nerve fibers that cross across the corpus callosum. This surgery is not curative, rather it prevents the spread and reduces seizure activity. So mainly the falls, and even most of the patients in the beginning of 2 months, they are actually they are off seizures, and few patients, the anti-seizure medications, the decrease in the number, and even the doses come down, the severity of the seizures come down, but it is not a curative procedure, it is a palliative procedure. So this is a case of corpus callosotomy. We do even endoscopic procedures, and I'm in the center of the brain here, that is interhemispheric approach, wherein you can see that that is a corpus callosum. Both are anterocerebral arteries. It is almost midway through the brain here. That is a corpus callosum. That is what we cut from beginning to the end. 4 corpus callosum, including from xeno to the spilium we cut, and anterocommissurus and posterocommissurus we add. Sign out of So, as told, corpus callectomy is not a curative procedure. It's palliative, and definitely it helps the patients because they are not left with any option other than continuing medications. And these surgeries really help them in preventing falls and even decreasing the dose of medications. Okay. So coming to hemispheric disconnection dissection, these types of surgeries are almost exclusively performed in children with seizure coming from large areas of one side of the brain, limited to one side of the brain. The procedure involves separating the area of the seizure onset from the rest of the normal brain. This typically is reserved for children with very large areas of seizure onset, and these include diffuse cortical dysplasias, panhemispheric Strouzover syndrome, large perinatal infarcts, hemimegalencephaly, and Rasmussen encephalitis, which is most common. There are 2 kinds of surgeries. One is anatomic hemispherectomy, where whole hemisphere is cut and taken out, and it involves the removal of frontal, parietal, temporal occipital lobes on one side of the brain, and deeper structure of the brain, mainly basal ganglia and thalamus, are left in place. So the other kind is a functional hemispherectomy, wherein we don't take the brain out, we just disconnect it, cut the wires, and leave the hemisphere in place, but disconnects it from the rest of the brain. So hemispherectomy, this is what we do, wherein we cut the whole hemisphere, frontal lobe, temporal lobe, and parietal lobe, we disconnect it from the rest of the basal ganglia, so that these cortical structures will not send the abnormal seizure activity down to the basal ganglia. So the results of these surgical procedures are quite good, actually, though you might be imagining now that when somebody is cutting the whole hemisphere, what is going to happen to the child? So most of these patients, they have hemispheric damage already, and there is something called as plasticity, where in kids, the other part of the brain takes over a period of time, and post-op, most of them, they have complete hemiplegia, and over a period of month, they walk to the hospital without seizures. And results is quite good. So far, the surgeries what we have done, only 1 patient has seizures on very minimal dose of medications, and rest of the patients are completely seizure free, and almost all on anti-seizure free medications are free. So generally, over 80% of people have marked improvement, seizure control, and many are able to free them from the seizures. Although it may sound surprising, as I told, new deficits of hemisphere are quite rare. Following major childhood injuries, the pediatric brain can often achieve substantial recovery of function due to the increased plasticity of the younger brain. The person's brain then develops relying on the good hemisphere that is opposite side. So other procedures are posterior quadrant disconnections. It is surgical treatment for refractory unilateral temporal parietal occipital lobe epilepsy. And there are other kinds of like occipital lobectomy, frontal lobectomy, where unilateral focal epileptic lesions involving the frontal lobe and occipital lobes, then we resect these lobes and try to control the seizures. Coming to lesionectomy, refers to surgical dissection aimed at curing epilepsy by removing structural brain lesions, mainly the malformations of cortical development, low-grade neoplasms, and vascular malformations. And because of lack of time, I will just skip these slides. Multiple circular transactions create small incisions, as showed by Dr. Shri in the previous slides. This technique is used when the seizure focus is located in the vital areas that cannot be removed, that is eloquent areas. It will be used alone or in combination with a lobectomy. So these are the last few slides. Neurostimulation, it's a recent thing. The neurostimulating devices are approved for the treatment of drug-resistant epilepsy. Vagal nerve stimulations, that the pamphlets given in your hand is one thing, and the other thing is RNS, responsive neurostimulation, deep nerve stimulations. Coming to results after surgery, appropriately around 60 to 70% of the patients are free from seizures that impair their consciousness or cause abnormal movements. 20% of the people may still have seizures that affect their awareness. And although this group continues to have seizures, the majority of people show a large decrease in more than 85% in number of seizures they have. So around 10 to 15% do have seizures without any improvement. So this was our article published on the journal. And we do it in Kanerimat, a small village, because these things are mainly done in metro cities, and most of the patients, they can't afford to go there. Even they have to go and spend money and they come back. And it requires a lot of pre-surgical evaluation and they cannot spend. So we have a surgeon trained in epilepsy surgery, totally different concept than conventional neurosurgery. There are very few centers to offer this training. Might be single digit in India, and Sri Chitra was pioneer, and I was fortunate to get trained there. And we have finance pediatric neurologist and epilepsy on panel, Dr. Mahesh Kamte, who happens to be my cousin and co-brother, who have complete infrastructure, including navigation, intro neuromonitoring, QSA, endoscope in-house. We have a CT scan, MRI, we have a top-end cath lab, we can do another evaluation also. Main thing is the finance support, because as you know that most of the patients with epilepsy belong to a poor socioeconomic background. Affordability is a big issue for them in the beginning of epilepsy, and are almost exhausted by the time they reach us. So being a charitable hospital, we do the vendor scheme, which is hardly 50,000 paid by the government, but we work on no profit, no loss. So we're able to do a good number of cases as center. So to summarize, surgical therapy offers hope for the improvement in quality of life for a wide variety of patients with intractable epilepsy. Advances in structural, functional, and metabolic imaging are greatly enhancing our ability to define the extent and nature of epileptic lesions prior to surgery, and therefore allowing us to make better decisions in surgical candidacy and operating planning. With proper training, team, infrastructure, interest in subject, it can be reproduced in second-tier city like Kolhapur with the same results. And despite the advancement of newer gadgets and sophisticated infrastructure in developed countries, epilepsy surgery needs more cost-effective options for developing nations. Expensive investigations, as in state-sponsored or insurance-funded healthcare system like the developed nations, may not be suitable for India. The fact remains that about 80% of candidates for epilepsy surgery can be recruited on the basis of easily available MRI and video telemetry. Thus, more centers take up the challenge of the surgical burden of epilepsy. Better days are perhaps not far away. Thank you.
Thank you, sir. I now request the chairpersons to present memento to the speaker. Dr. Shivshankar Marjake, sir.
I thank Dr. Shivshankar Marjake, sir, for such a wonderful and lucid talk. In a simple yet effective way, he could reach the public, which is a non-neurological public, the effectiveness of the epilepsy surgery. And believe me, it can be life-changing. Thank you, sir.
One more thing, wonderful job he is doing at a small place like Kanerimat. That is really wonderful, wonderful. Serving people of both Maharashtra and North Karnataka, especially who are not affordable to go to Nimans. So for which he need loud applause. Please.
Thank you, sir. Thank you, ma'am. Now I request Dr. Ashwini Hiramat, ma'am, to present memento to the chairpersons.
Thank you, ma'am. The next talk is on non-epileptic attack disorder and mimics. For this, I invite neurologist and movement disorder specialist, Aster RV Hospital, Bangalore, Dr. M. Abbas, sir. I request the chairpersons, Professor, Department of Medicine, Medical Superintendent, Dr. R.M. Honotigi sir, and Professor, Department of Medicine, Dr. Mallana S. Mulimani sir, to chair the session. Over to you, sir.
Thank you for this opportunity. I'll just keep my talk short for the want of time.
Good afternoon. Today we have amongst us Dr. Mirza Masum Abbas, who is a consultant neurologist, and he's there with us for last 1 year, regularly visiting us every first Thursday for his academic and also for his consultant practice. Brief introduction about Dr. Mirza Masum Abbas. He's a consultant neurologist, and his special interest is in Parkinson's and movement disorder. And also he's working as movement disorder specialist at Parkinson's and Aging Research Foundation and Sparsh Specialty Hospital, Bangalore. He's also visiting faculty at our college. And Dr. Abbas has completed his neurology training at Nimans, Bangalore, and received his fellowship in Parkinson's and movement disorders from National Neuroscience Institute, Singapore. His areas of interest include Parkinson's disease, dystonia, tremors, ataxia, and other movement disorders. He also has significant expertise in functional surgeries like deep brain stimulation in movement disorders. He has more than 30 publications in various national and international journals to his credit. Today, in under next 20 to 25 minutes, he is briefing us about no, sir. Non-epileptic attack disorder and mimics, which are very much challenging for diagnosis and also management. Over to you, sir. Thank you.
Thank you for this kind introduction. Well, once Dr. Ashwini asked me to chair this session, I was a little skeptical because of two reasons. One, I practice more of a Parkinson's and movement disorder. And second, it's a concept of non-epileptic attacks, which belongs to a larger domain of a functional neurological disorder. So we have two approaches in as a physician, as a neurologist. We have a disease, well-defined disease, we give treatment and the patient improves. That's what I think till now we had all the talks. We have a defined structure which we can, treat with medicine or with the surgery. Second is when they have a lot of psychiatric issues, when we refer them to the psychiatrist. The third domain is what I'll be discussing now. It is functional neurosurgery, neurological disorders. Why I was uncomfortable was the training what we receive is awfully incompetent for us in general practice to treat this kind of people. So like in NIMHANS, I would have seen every week 2 cases of a mitochondrial disorder, Leigh syndrome and all, which in last 10 years, I would have seen only 2 patients. And every week I see 2 patients of these functional neurological disorders, which we have not been exposed adequately as a physician when I was doing my MD, as well as, in my neurology practice. So whenever a patient presents with a loss of consciousness as to a general physician or to a neurologist or to a ED, only 60% of these patients have a genuine epilepsy. 20% of these people can have a syncope, and more than 20% of these people have a functional epilepsy or non-epileptic disorder. So where did we neurologists or physicians went wrong is we divided it into a very, for us easy basis, neurology or a psychiatric. And even in neurology, we kept dividing it to epilepsy or a movement disorder. Like every week, my friend Kenny is there. He calls me up and say, "Okay, sir, ye to functional hai." So he sends to me. And I keep counseling them and I keep hoping God some psychiatric issues turns out and absolutely there won't be anything. Then I'm lost. Then I keep counseling them about these functional disorders and all. The only question patient will ask is, what next? So I keep telling them the psychology and this and that. Ultimately, they are not convinced and they continue their journey of doctor shopping. So this is a domain where we do not, the clinical examination of the history and the examination do not fit into a classical pattern of a neurological disorder. It falls in a gray area between the neurology and the psychiatry. It's very difficult to diagnose. I still remember one good line in Victor Adams I used to read. Myasthenia, if you diagnose as functional, the doctor does not know either myasthenia nor the functional. So they should have a proper knowledge about what the diagnosis is, which I'll speak in next few slides. The second most tough part is how to explain the patient, because they come up with a lot of investigations and everything turns out to be normal. So it is very difficult to convey the patient what they have. The third most difficult part is how to manage, because unless only 20% of these patients have some defined psychological psychiatric component, if that can be amenable to psychotherapy and a psychiatrist thing, majority of them we are awfully incompetent, means we cannot offer them anything, neither the medicine. I show you in next few slides how they can affect it. So I was reading 20% of neurological disorders have this functional neurological disorder, and 60% of neurological disorders have a functional component to it. So we have to look at a broad picture of evaluating and managing these people. So now for the last few years, we have realized our incompetence, and there's a new group called Functional Neurological Disorder Group, and we are trying to study this more thanks to the lot of functional MRIs what we have. So now there is a concept of, this lumping versus splitting concept. Now we are taking a holistic view, like what the gastro people do in irritable bowel syndrome or the rheumatologists do in fibromyalgia. Same thing we are coming up in the neurology. So we come up with the core concept of FND, like epilepsy and movement disorder, they actually fall in the same spectrum. We can also have functional weakness, functional sensory deficits. Some people keep on coming, you might have seen in OPD practice, I have a memory loss they come up with. So this partly can have a functional component related to underlying stress. So bowel bladder issues, swallowing, speech issues. In addition to that, they have a psychological component. So we should see it in a spectrum rather than, isolating ourselves with some isolated disease. So as I was telling you, there is more and more study about this pathophysiology based on the functional MRIs. And now there is a concept of, agency, emotion processing, and attention. Before I go to that agency, I would like to have few words about the concept of free will. So you might have heard this free will means I am planning something and I try to do that activity. So willingness and self-agency. Self-agency means I do some activity. So, philosophers for thousands of years, they have debated on this. Okay, I am thinking and I am doing the action, so I am responsible for these actions. So other people say, okay, and God is judging. Okay, the second view is God has made us, and so whatever actions I do, it's a part of Him. So I should not have any blame. So this is the philosophical debate of will and agency, which is going on. Then one of our great professors, Professor Mark Hallett, is a godfather in movement disorder. He said, look, I cannot measure the willing and thinking part. What I can measure a movement. So what he came up with the concept is a neuronal circuit wherein you think to do a movement that is done by the supplementary motor cortex. The motor cortex in turn goes and does the movement. That is called self-agency, means I thought and I did the movement. Then I just can't stop it. The brain has to know that I have done the movement. So it sends a feed forward mechanism to the sensory cortex, the parietal lobe, wherein the brain gets a sensation that, oh, this movement has been done. And it again sends a feedback, means it's a loop of feed forward and feedback mechanism. So sometimes what happens, this mechanism gets disrupted. When it gets disrupted, the right temporoparietal junction gets activated. So the importance of this area is, whenever I am doing a violational movement, my brain thinks that it is involuntary. So that's the crux of all functional neurological disorder. I can show a lot of videos where people have a lot of funny movement. I tell, why are you doing this? It's a classic voluntary movement, but they say, okay, no, I am not doing it. There's no anxiety, no feeling, it's not malingering. They just are not aware that this movement is voluntary. So that's the main crux in the all FNDs. The voluntary movement appear involuntary. Okay. The second part is emotional processing. We have a salience networks involving the cingulate, the parahippocampal, hippocampal, and the limbic areas. What it does is how we process our emotions. So most of the salience network form in early childhood about your upbringing, how tough you were, how was your relationship with your parents, siblings, and all. So it makes you how you react to a stimulus. So we see a lot of FND people, they have a lot of tremor. I show you a video. They're not concerned. So they are not concerned the moment is happening, or they might show excessive panic, or they might show excessive emotional reactivity. Their limbic cortex can get activated with a lot of physiological signs. For example, after non-epileptic disorder, people start panting as if they have run a marathon. So that's a deficient emotional processing. Okay. The third third important concept is attention. So how much attention am I giving to this moment? Again, as I told you, misdirected attention. People might whole life, they might just be bothered about this some movement happening. That is the dorsolateral frontal cortex. These three areas are not working, in tandem. They are all working together to present a movement which ultimately look like a involuntary, at least to the patient. So it proceeds in three ways. So as I told you, the predisposing factors used to be there, like low socioeconomic care, this thing, comorbid neurological disorder. That's one of the reasons why majority of epilepsy surgeries, after the surgery, they keep on throwing a pseudo seizure. Okay, because they know what seizure is, and it's a predisposing thing which they get subconsciously. It happens to a lot of our Parkinson patients. Post pre-DBS, they are all dependent on the caregiver. Moment you do DBS, they are on their own. They subconsciously, that caring, that attitude will go, and they keep on feigning again the thing. So subconsciously, they want that attention. So premorbid, how your condition, it makes a sense to start this movement disorder or epilepsy. The precipitation usually is some event, some accident which can precipitate. 10 years back, we had a concept that dystonia is often precipitated by a injury. So that leads to dystonia. Now we know that it's a functional thing which precipitates the dystonia. Okay. The most important thing what I want you people to understand, even if you do not understand FND, that's okay. So these precipitating, perpetuating factors you should be aware of. Like, when I was PG of your age, a lot of people used to come with loss of consciousness in ED. So we used to do a lot of funny stuff, which I feel sorry and funny. We used to put riles tube, we used to jump on their sternum, and we used to give this and all that stimulus. So what it does, it subconsciously forms what you call that network gets stronger and stronger. So, or we ridicule them, we laugh at them, okay, oh, this is a functional case, or we keep telling them there's nothing. So all this kind of very broad generalization, all this will increase the burden of continuing the cycle of continue to having this moment. And the other most important thing is, if you cannot diagnose, as I keep telling my students all the time, please send to somebody who can. Please do not do unnecessary investigations, unnecessary EEGs. Every day, as I told you, every week I see 2 patients like this. They go all over the India with the burden of investigation. I tell them there is no. Then the subconsciously patient thinks, oh, I have some big illness which even the doctors are unable to diagnose. So the diagnosis of functional neurological disorder is based on positive signs, not based on ruling out everything. Okay, so you should have your eyes open to see 2 things: whether it's a functional neurological disorder. Second, how much functional element is there in any neurological or a non-neurological illness. So I give a personal example, like we give a lot of Botox to hemifacial spasm. So I came up a lot of, I'm not criticizing, but a lot of women, they come up, they are never happy. They are like, abhi ye nahi ho raha, abhi wo nahi ho raha, because emotionally they are cosmetically very, bothered. For a man, if his eye open, he's very happy. Yeah, it's done, my job is okay. So, because that's the emotional network, salience networks, what they have, how they react to a stimulus. So each person completely relieved post-surgery, post-DBS, still they keep complaining because of the subconscious behavior, illness behavior, what they have. So most important, because I am giving so much lecture because we do not have definite medicine for this. So what at least people can do, stop this perpetuating factors, which can lead to a, 20% of these people are permanently disabled, 30% are chronically ill. That means 50% of these people are not fit to be within the society. Okay, I show you a patient. Years together, they go on with this kind of a illness. Okay, so what at this point of time we can do, at least give them a patient hearing. Don't try to be supportive or criticizing them, and don't try to perpetuate it with an illness behavior. So coming to NIIDs, there are a lot of other names which we use, like paroxysmal non-epileptic seizure, functional seizure, disorders. All these names are because we are not sure how to define this. So the present definition is, it can be a paroxysmal psychic sensory motor manifestation, which looks like a seizure, but EEG is not normal. Okay. So how to differentiate at your level, whether it's a seizure or a pseudo seizure? Pseudo seizure we don't use nowadays, because pseudo means patient is doing, which is actually not true. It's happening because of the functional network. Okay, so these people can have a very gradual onset. The aura can last for days together before it starts. The most important is, whenever you are using 5-6 refractory, when you refer to a surgeon, it's a refractory. Always look whether you are dealing with a functional seizure, rather than subjecting patient to all the new investigations what the previous speakers told us, fMRI, PET, because that might pick up something. Okay, last week I did one DBS. Before MRI, it picked up a meningioma, and it was in the line of the tract. Okay, so unnecessary we do investigation, you get one, that scar, and we unnecessarily chase that, that is causing it. 40% of refractory epilepsies are PNES, functional epilepsies. Okay, usually do not happen during sleep, and they have a vivid collection of the seizure happening, which doesn't happen with a normal seizure. Okay, so they have a multiple seizure semiologies. The most important thing is, in seizure or a movement disorder, changing semiology. The semiology keeps changing with each attack. So that is a strong indicator as a pseudo seizure. And during the seizure episode, we look at involvement, organic brain involvement, like an extensor plantar or oculocephalic reflex or a corneal reflex, which can be there in these people. Okay, and eye closure. But the most important what we see is, if you have a tongue bite, my professor always used to say, lateral tongue bite cannot be produced by a pseudo seizure. It always has to be a normal, true epileptic seizure. Okay. So lab parameters are not of much help, more of a video, like Dr. Ashwini was telling. You have to see the video and see what is happening. And nowadays, I think it's unethical. Before we used to do the suggestions, give intravenous saline, IM injection. or we used to say it precipitates a seizure by vibration. Now people think it's unethical because you are fooling the patient by telling that it happens. And once the patient comes to know you are fooling him, the doctor-patient relationship goes, and that whole disorder will go for a toss. So he'll start not trusting you, and it keeps on perpetuating the cycle. Okay. I consider movement disorder as a spectrum of the same, just that we see a different semiology. Like if I see a tremor or a dystonia, I see the patient. If they see such kind of seizure, Kinney will see that as an epileptologist. Okay. So as I keep on repeating, the primary thing is voluntary movement they perceive as involuntary. And please diagnose based on these positive findings. The positive findings are the movement should be variable, it should be distractible, and any attention like you are watching that movement get worse, and inconsistent movements, incongruency between the neurological finding and a known disease, and suggestibility. So based on this, rather than absence of investigative evidence, should be the criteria for diagnosis. So coming to management, as I told you, it's more of a multidisciplinary care. So please spend a lot of time with them, try to understand what is causing them. If not the movement disorder, we can try to take care of underlying anxiety or the depression or the mood. And most important, keep them occupationally active. I've seen two people, rank students sitting at home because they are bothered only about this movement and they're spoiling their lives. And over attentive parents, they keep on showing a lot of care, and it makes a cycle, subconscious gain, and they just sit at home. So try to keep them as occupationally active as possible. Okay. Try to convey the diagnosis in as simple term as possible. Accept that this can be reversed, but it takes a lot of time. So other mimics, I'll just take few minutes. The most important you should be aware of is a syncope, because it's life-threatening. Any patient in old people, if you see this kind of thing, video in that. So I think there was a video, it's not here now. Syncope, always you have to look for a cardiogenic cause, because it is extremely important and life-threatening. Okay. The second being sleep-related disorders. Many of these people come, jerks in the sleep, which is common. Sleep myoclonus is physiological. You should assure them nothing to worry. And most common misdiagnosis is the REM behavior disorder, which we see in Parkinson. Invariably, somebody would have put them on anti-epileptics. So how do we differentiate? The sleep-related disorders have a lot of behavior, emotional component to that, and occurring at a particular part of sleep. So most important, if you have a doubt, just do a overnight sleep study. Okay. So the others, I think we know by history, TIA, and the other is paroxysmal kinesiogenic dyskinesia, which is very well treated by, a small dose of carbamazepine. So inadvertently, they treat a seizure and they respond. So hypoglycemia, I should never miss. Demyelinating disease. The list is exhaustive. I've just given a very small list. Okay. So the idea of this talk is to sensitize you people on the functional neurological disorders. They are very common. Even a neurological disorder can have a functional component to it, not just a neurology. I think physicians also know, a lot of general medicine practice, we see a lot of a functional component to any illness. Okay. So it is important to identify them and positively approach, rather than, put it under the carpet like what we've been doing for so many decades. Thank you.
Thank you, sir. Thank you, sir. It was really wonderful.
Yeah, as I told you, we used to do that. Now I think there's a lot of ethical concern. So if I tell the patient this can cure it, and if they come to know it is a lie, so you are liable for a medical negligence. And second, it breaks the bond between you and the patient. They'll think, you have fooled them. No, use of placebo to treat a FND telling that it will cure is unethical. You are understanding? You can give, we do that gabapentin, pacitane, something we give, just for the want of giving the medicine. So what I'm trying to tell you, the whole approach of FND has changed. Now we should look at the broader spectrum of all the diseases which we have, and we should approach each of them. Okay. So rather than, like I told you in my physician days, we used to give that, give one injection IM. We were very fond of one B12 bottle, which used to be colorful and all that. So now it's not, because it breaks the trust. Patient thinks that that's the treatment. Okay.
Hello, sir. Any questions? Thank you, sir, for highlighting the non-epileptic movements. Most difficult topic. Sir, I have seen one patient who was proved epilepsy, a boy about 16 years. He used to develop this non-epileptic functional movements. Very, very difficult to diagnose unless we see the patient and record the videos. Thank you, sir. Thank you for highlighting.
Thank you, sir. I request the chairperson to present the memento to the speaker, Dr. M.M. Abbas, sir. Thank you, sir. I request Dr. Anand Chaudhary, sir, to present the memento to the chairperson. Thank you, sir. Thank you, sir. For delegates, lunch has been arranged at the cafeteria, first floor of the boys' hostel. Post lunch, the second half of the scientific session will commence at 2 p.m. Kindly return to the hall by then.
Very good. Yes. Yes. ನಾನು ಮಾಡ್ಲೆ ಬರತ್ತದಿಲ್ಲ ಗ್ರೀನ್ ಬರತ್ತದ ಮಾತಾಡ್ರಿ ಏನ್ ಪ್ರಾಬ್ಲಮ್
ಏನಂತ ಸ್ಕ್ರೀನ್ ಶೇರ್ ಮಾಡ್ಲಾ
ಅದು ರೆಡಿ ಅಂತ ಬರಾಬರ್ ಐತೆ ಅದಕ್ಕೆ ಮಾಡುತ್ತೆ ಎಲ್ಲ ಹೊಲಸ್ ಹಿಡಿದ ಯಾರು ಒಳಗಡಿಸ್ತಾನೆ ಆಪ್ ತಗೊಂಡ್ಬಿಟ್ಟು ಮಾತಾಡ್ರಿ ಮಾತಾಡ್ರಿ
Excuse me. Can you hear me? Hello? Hello?
Check.
We can share the screen and ಮಾಡ್ಲಾ Ashwini, are you there?
I request everyone to come to the hall. I request all the students to come to the hall. We'll be starting the session very shortly.
For sharing the screen. Excuse me.
Teacher is faster than the students.
Is anyone there in the hall?
Good afternoon to everyone.
Hello?
Good afternoon to everyone. Good afternoon, ma'am.
Yeah, can I share my screen now?
Yes, ma'am.
Okay.
I request the chairperson, Dr. Anand Chaudhary sir, consultant neurophysician, Basava Brain and Spine Center, and Dr. Shailaja Bidri ma'am, professor in HOD Obstetrics and Gynecology, to chair the session. Over to you, sir. Over to you, ma'am. Now I invite Dr. A.O. Saroja ma'am, Senior Professor, Neurologist, JNMC Belgaum, Honorable Secretary, KNA, to talk about epilepsy in pregnancy.
Elrigu namaskara. Good afternoon to each and everybody. I'm very grateful and thankful to the organizers who has given me the opportunity to introduce such a dignified and elegant ma'am, Dr. Saroja ma'am. She is working in KLE University, JNMC Medical College as a professor of neurology. Ma'am has completed her MBBS from MR Medical College, Gulbarga, and she completed her MD Medicine from JJM Medical College, Davangere, which happens to be my alma mater also. And ma'am completed her DM Neurology from prestigious Institute of National Institute of Mental Health and Neurosciences, NIMHANS, Bengaluru. And ma'am has a teaching experience in neurology of more than 25 years. And ma'am has worked as a senior resident, assistant professor, and associate, and now she is working as a professor in Keli, Belgavi, and ma'am has a vast experience in teaching and clinical knowledge of neurology, and ma'am is very specially interested in neurological sub branches like cognitive neurology, cerebrovascular diseases, neuroinfection, and epilepsy also. And ma'am has many publications in her name, and she is also awarded with many awards in paper presentation and clinical research studies. And she is also the members of many prestigious professional neurology bodies like Indian Academy of Neurology, Indian Stroke Association, Indian Epilepsy Association, and Clinical Neurophysiology subsection of Indian Academy of Neurology, Cognitive Neurology subsection of Indian Academy of Neurology. And Madam has credit to a chapter in textbook of neurology in IIN that was published in 2018. And Madam has more than 20 to 30 publications in national and international level or international journals. And this is all about ma'am. And now over to ma'am.
Okay. Thank you, Dr. Anand Chaudhary, for those flattering words. And I would thank all the other, chairpersons also. And I would like to thank Dr. Ashwini and her team for giving me this opportunity. I regret for being not there in person, and I'm sure we can always meet sometime. And it's a nice thing to talk to all of you. I've been asked to speak on pregnancy and epilepsy. And if you see this lady with pregnancy, there are thorns around. So let's see if we can make her life a little, less cumbersome. So with this, just a second. Yeah. I have no disclosures. I would like to say I'm a general neurologist and not an epileptologist. So as we also deal with a lot of people with epilepsy in general way, I would like to, share my experience with all of you. And in India, you know that so much of gender inequality is there. I'm not a feminist, but as a doctor, I have seen how women suffer. And the males and the females, there's a lot of inequality when it comes to epilepsy. Let's understand why this happens. And so the thing is that we'll see, especially for a girl child, when she's born, and then she develops epilepsy, that is where our journey with that patient starts. So we need to see that this epilepsy is not causing too many seizures. Her seizures are well controlled. Her education is not hindered, and she grows up to a graduate, independent. And these are the problems that we face in relation to her schooling and seizure control. That is where we are concerned about. And then the next, when she grows up into a reproductive period, that is when we have the stigma that comes up, because she's in a marriageable age. And this is where all the problems start. And at this time, other than epilepsies, to her gender, she can also have catamenial epilepsy. I'd like to just define gender and sex here. Sex is like when we say male and female, and this is all based on chromosomal and physical characteristics. When we say gender, it has a socio-cultural background. So I would always respect a gender. Here, gender inequalities in relation to epilepsy. So this is when we start preparing her for her marital life, what she should do, how she should, take care of herself. And so next she goes into a married life. This is when she's worried about contraception and fertility. We'll talk about that in a greater detail in the next few slides. And then next, the pregnancy. So we are involved from childhood to a pregnant lady and to the postnatal care also. So what is the burden of epilepsy? We all know that this is the commonest neurological disorder that we, all of us as general neurologists, medical specialists, pediatricians, gynecologists, all of us come across epilepsy in our walks of life. And so my talk would be, concentrating on burden of epilepsy. At the end of this talk, we'll see if we can learn something or share with all of you in relation to burden of epilepsy, outcome of seizures on the mother and the fetus and baby, and the effect of anti-seizure medication on the women and fetus. We'll also talk a bit about fertility, pregnancy, contraception, and then the preconceptual period, which is very important for counseling, pregnancy and postpartum care, and of course, breastfeeding. So coming to burden of epilepsy, there are 12 million people living with epilepsy in India. For a country of 130 crores, it may not look very big, but this is in relation to not just the number, in relation to quality of life and the people who are concerned with this woman with epilepsy. So the prevalence of general epilepsy in general population is about 4.7 per thousand. And it's one of the most common neurological disorders in pregnancy. And it carries not just the disease burden, but also the stigma which is attached with this. As I told you, the gender inequality. A male person or a man with epilepsy will not have so many problems as much as a woman having epilepsy, because she has difficulty in getting getting married. So 0.3 to 0.8% of all pregnancies, may have epilepsies. And we are concerned about fertility issues, effect of seizures on the mother and the baby, and of course, the anti-seizure medications and their teratogenicity. So we need to understand why pregnancy is a special situation. This is because of the sex hormones. Now we know that hypothalamo-pituitary gonadal axis, it has got reciprocal connectivity with the temporoparietal cortex of the brain. And then as the tertiary products of this HPG axis, we have the hormones, estrogen and progesterone. And what is the effect of estrogen? It facilitates kindling. Kindling is a process where the brain is, epilepsy develops in the brain. So this process is accelerated and facilitated by estrogen. And it also reduces the seizure threshold through glutamate receptors. So in that way, estrogen is almost like a pro-convulsant. Now coming to progesterone, it modulates GABA, which is an inhibitory amino acid. In that way, it has got some anticonvulsant properties. So we know that patients with epilepsy are known to have menstrual dysregulations. And these menstrual dysregulations can also be not just due to the disease burden, but also because of the anti-seizure medications, or we don't call them as anti-epileptic medications because none of them can prevent epilepsy. They can only abort seizure. So I will be using only this term, anti-seizure medication. These enzyme-inducing anti-seizure medications, that is the cytochrome P450 enzyme, if it is induced, it will reduce the sex steroid levels like the estrogen and progesterone, which can lead to contraception failure. These drugs are also known to cause polycystic ovarian syndrome, for example, sodium valproate. And then it can also produce menstrual irregularities and premature menopause. These are some of the effects of anti-seizure medication on the woman. So the epilepsy patients, they are also known to have sexual dysfunction. And this is because of drug-induced libido. So like, some of the anti-seizure medication, they can decrease libido. And the seizures per se can cause sexual dysfunction. And these patients with epilepsy have comorbid mood disorders. And fertility treatments, which is come up in a big way to help the mothers who have, to help the women who with infertility. These fertility treatments, if they have higher estrogen levels, they may exacerbate seizures. But however, the good news is if the woman has no pre-existing infertility, she has as many good chances of conception as the general population. So now what is our role? So preconception period is the most important period. As I told you, before they get married, they need to get counsel. It's our duty to talk to the patients, not just the prescribe the medication. The earlier I reach the prescription pad, the least I know about the patient. So as neurologists, we need to have a good history of this patient, how she has behaved, what is the type of seizure, what medication she's taking, what are the provoking factors. So we need to, counsel these patients premaritally. And in globally, 60% of the pregnancies are unplanned. It is a very difficult situation, and I'm sure all of us have gone through this. When patients come, when the patient realizes that they are pregnant, it's already about 4 to 5 weeks. By that time, the neural tube has already closed. So we cannot control this teratogenicity due to anti-seizure medication because of the undetected or undiagnosed pregnancy by the patient or the, by the failure of the doctor to inform these patients about periconceptual medications which can prevent this teratogenicity. And then we need to have a very good seizure control so that if the patient has been seizure free for about 9 to 12 months, this lady is unlikely to develop seizure recurrence during pregnancy. And then we need to have a proper selection of anti-seizure medications. We'll talk about periconceptual folic acid, which is known to reduce the teratogenicity. And most important is to monitor the drug levels during pregnancy. And we need to talk to the patients and their caregivers about teratogenicity. We need to have some idea about this. And it is just that we need to care these pregnant women throughout their pregnancy up to their postnatal care. So some of the physiological changes, all of us know that there is increased blood volume, altered serum albumin, there's increased renal blood flow, and induction of hepatic metabolism. All these will reduce the anti-seizure levels, medication levels. So they are likely to have seizures because of the reduction in anti-seizure medications. To add to that, these patients are known to have hyperemesis so that, they can vomit the drug and reduce the drug levels. And most of the pregnant women become somehow, they are scared, they don't inform anybody, they don't find out, and they become non-compliant. And it is a very, this thing that we see among the, in our practice, that the doctors advise them, not the neurologists, advise them that the taking anti-seizure medication is detrimental to the fetus. So they listen to them and then they stop the medication or change the drug abruptly and come to us. And we all have well-wishers around us who will, even though they are not doctors, they continue to advise us regarding, the healthcare. So most of them stop, pregnant women may stop the drug and then come to us after the seizure has occurred. So, and then all these things, the physiological changes and hyperemesis can reduce the levels of anti-seizure medication, which can cause seizure to occur during pregnancy. Now, the next thing that we need to know is what happens to the seizures in a patient who has epilepsy and becomes pregnant. It's a very good news that 2/3 of them remain seizure-free. Some of them do improve, as I told you, because of the progesterone. And then only it is about 15 to 20% of patients who can have seizure recurrence. And it's not a big number for us to manage these patients. And if the patient has genetically determined generalized epilepsies, not the symptomatic epilepsies, they are better off. They have less chances of recurrence than the focal epilepsies. And we need to know we have some good drugs, bad drugs, and ugly drugs. All of us know that the newer drugs like levetiracetam and lamotrigine, they are less teratogenic. But unfortunately, these drug levels during pregnancy fall precipitously during the first trimester. That is when the seizure occurrence can can occur, seizures can occur because of the reduction, and we don't know that these drugs are reduced, and then we may not increase the levels. So we need to keep this in mind when we are treating patients with epilepsy. Now, what are the predictors? The predictors of seizure recurrence are supposing the patient has seizures before becoming pregnant. If they are on polytherapy, more than one drug, that means they already have some resistance. Focal epilepsies are likely to recur more than the generalized epilepsies. And as I told you in the previous slide, that lamotrigine and levetiracetam reduce during pregnancy, the levels reduce, so that may give rise to seizure recurrence. Now, what is the outcome of seizure on the fetus? This seizure, if they have generalized seizure, the lady has generalized seizure during pregnancy, it can affect the fetus, it can cause fetal hypoxia, lactic acidosis, and then focal epilepsies. Just one single focal seizure can produce bradycardia for about 2 to 2.5 minutes, which itself can give rise to fetal hypoxia. And the other complications on the fetus include neonatal hypoglycemia, that's on the baby, sorry, neonatal infections, increased stillbirth, spontaneous abortions are a little more common, and the baby can have small for gestation and low Apgar score. So these are the effect of seizures on the fetus and the baby. Now, what is the effect of epilepsy on pregnancy itself? As I told you, very good, we can say confidently that 90% of the pregnancies end up normally, even in patients who have epilepsy. It's only 10% who probably are not monitored. They do not have a skilled care. They are likely to have problems. Now, what are the problems to the mother because of seizure recurrence? So it's shown in studies that maternal mortality is 10 times higher as compared to general population who are the pregnant ladies with no epilepsy. And the other causes are spontaneous abortion, gestational hypertension, preeclampsia, breech presentation, increased cesarean. This is the increased cesarean is because, not because the patient has problems, it's because the doctor is scared that the gynecologist or the obstetricians, they are scared. So they tend to, perform cesarean more often in these patients than the general population without other comorbidities. And then also these people are found to have increased induction of labor. Again, the reasons are same. So now, when we talked about the effects of the seizure on the pregnancy, effect of seizures on the baby and the fetus, now we'll talk about what are the teratogenic effects because of anti-seizure medications. Compared to general population, that is pregnant ladies without epilepsy or on without medication, the patients with epilepsy on medication, they have threefold increase in major congenital malformations. We are not worried about minor congenital malformations because some of them can be just cosmetic. But here you have 7% versus 2.28. So there's a threefold increase in major congenital malformations due to teratogenic drugs. So some of the major congenital malformations include musculoskeletal abnormalities, cardiac abnormalities, neural tube defects, craniofacial, like facial dysmorphism, cleft lip, things like that, urogenital, like hypospadias, they can have renal, poor development, and most important, which is least recognized, is the neurodevelopmental and the cognitive or the IQ of the baby. So these are some of the malformations that you get, both the motor and then the psychomotor, in relation to the anti-seizure medications. Now, what are the risk factors for developing these congenital malformations? One is it is dose related. That is, the larger the dose, the higher the malformations. If the patient is on monotherapy, she's less likely to develop. Polytherapy again increases. And if these are some of the, I'll just come to that a bit later. I just want the students to see that these are the malformations that you can see: the cleft lip, cleft palate, cleft lip and palate, and they also have neural tube defects like spina bifida occulta, or there is a defect in the spine, so there can be protrusion of the meninges and the spinal cord. So meningocele, myelocele, these are some of the neural tube defects. And others are like facial dysmorphism, cardiac defects like patent ductus arteriosus, congenital heart diseases are also can occur. Now, as I told you, good, bad, and ugly. So we see valproate stands high in relation to malformations. So that is about 10 to 11%. Primidone is a drug which we don't use that commonly. It's used for other diseases, not as a main anti-seizure medication. Earlier it was used, now we don't use it much in our general practice. And then phenobarbital is of 7%. Phenytoin is 6%. These are all the older drugs, phenytoin, phenobarbital, and primidone. The newer carbamazepine. The newer drugs like lamotrigine, topiramate, and oxcarbazepine, levetiracetam. These are like almost lamotrigine and levetiracetam are almost like general population. As I told you, congenital malformations do occur normally also in patients without seizures. That's about 2 to 2.8%. So similarly, lamotrigine, levetiracetam almost are like patients without epilepsy or drugs. So the most important is the valproate, though it is a very good drug as an anti-seizure medication, but when it comes to pregnancy, it's not good. It's good for epilepsy, but not good for pregnant ladies. So lamotrigine, as I told you, it's almost equal to general population without comorbidities. Now, if you see this, these are some of the defects. Like if you see the red thing, this is the cardiac defect, which is most common with phenobarbital. And if you see valproate, you have cardiac, you have neural tube defects, and also the hypospedia almost in the same level. And then these are other drugs like carbamazepine, lamotrigine, barbiturates, that's phenobarbital. You see very little with levetiracetam, and then topiramate. Of course, this study is like it had very few patients. So I mean, we cannot take this graph because when topiramate, in other studies, they've shown that topiramate is as bad. So these are some of the studies which have included registries like the Australian pregnancy registry, Irish registry, and it also included Kerala registry. So Kerala, they have a good pregnancy registry wherein they have shown. I'm sure you listened to Ravish in the morning. He also was a part of this another study that's part of Kerala registry. What did they show? They showed that most teratogenic effect is with sodium valproate. This is what you see. Lamotrigine, levetiracetam, and oxcarbazepine are almost like general population. And then when we combine that, monotherapy is better. And then this is the motor defects. Now, IQ also, we are these days, it's a competitive world. We are not only worried about the baby's congenital malformations, which are motor, but we also look at their IQ. It has been shown in studies that the children who were mothers who were on valproate, so the children born to these mothers who were on valproate, they showed that IQ at 6 years was less. Not only that, they had increased autistic spectrum disorders, and they have increased linguistic problems. So valproate is not only teratogenic in relation to motor, but also with the not only motor, it's also psychomotor. So developmentally also these children lag behind. But good thing is these are all dose related. So if the patient is on a smaller dose, they are unlikely to develop compared to those patients who are on larger dose. So you can compare high dose carbamazepine with the low dose valproate, almost equal. Though we think that carbamazepine is good, but if you're using a higher dose, you may have as many defects as with valproate. Now, this is the flow chart that shows the good drugs. These are lamotrigine and levetiracetam. Next comes oxcarbazepine. We don't use gabapentin because it's not a good anti-seizure medication in India. We don't use that. In the West, still they use. Then carbamazepine, all of you are aware of this drug. This is relatively not a very old drug, but it's not new also. It comes in between. So we know that these drugs, all of us have heard of phenytoin and phenobarbital. They are not good. So the ugliest drug in relation to teratogenicity is the valproate. So this is the lowest risk and this is the highest risk. This is the spectrum. Okay, now there are newer drugs which have come up: perampanel, eslicarbazepine, lacosamide, and brivaracetam. Now, lacosamide has enjoyed for the last few years. It's a good add-on and a primary, first-line drug. And they've shown in studies that few studies only that it has not shown any malformations. It's a good drug in relation to, its anti-seizure activity. Now, like levetiracetam, this is a modified form of levetiracetam, that is brivaracetam. They have shown very few defects, but what we lack is the data is not robust. We have inadequate data. We need some more studies and some more data to come so that we can confidently say that these drugs are good enough. Now, what are the risk factors for teratogenicity? As I told you earlier, higher the dose, higher the malformations. And if you're using more than one drug, that is, if it includes the additional drug includes valproate or topiramate, their chances of developing congenital malformations are more. So it's not just the mother who matters. If the mother has congenital malformation, child is likely to have more risk. And if the father of the child has malformation, the child also is likely to have more risk. So other thing is that if the mother has one child with major congenital malformation, the second child will be 20%. And if the mother has child has two congenital malformation, the risk will come almost to 50%. And the worst drugs are valproate, carbamazepine, and topiramate. So these drugs, when they are included in combination, you will have major congenital malformations. Now, this is same Ravish, whom you listened to in the morning. He was a part of this Kerala registry. From this study, what they say is it's not just the polytherapy, it is the dose that matters. So higher the dose, higher the risk factors. So they also felt that if the patient was on polytherapy with a smaller dose, they may be slightly better. So now neurodevelopment. Why is this anti-seizure medication? How do they affect neurodevelopment? Because we know apoptosis means it's death of neurons. So this anti-seizure medication, particularly valproate, it causes increased neuronal apoptosis. Even with lower dose, that is subtherapeutic dose, it's shown to produce neuronal loss on the brain, of the fetal brain. And neurotrophin is the growth hormone like thing. So it decreases neurotrophin, decreases neuronal survival promoting proteins, and neurogenesis. Neurogenesis is new neurons being formed. So it causes increased death, decreased genesis. And then valproate is that in that way, that is the reason why the children are born with lower IQ. They have delayed cognition. They have poor linguistic skills. They can have attention deficit hyperkinesia, and they can have autistic spectrum disorder. So, and one thing is with age, it improves. So it's a good thing if they can be identified in the beginning, it's better. They can get some training, and they can be still made to, perform better in their school. So now how do we manage this? We know what are the problems. So most important is talk to the lady, and she has to plan her pregnancy, because we need at least a year before we can switch over the drug. We cannot switch. Supposing the patient has done very well with valproate, and then we want to switch over, we cannot do it after she conceives and comes. So we need to tell her, if you're planning pregnancy, and then we can switch over because we have time. What happens is, if we plan, if the lady is, seizure free for about 9 to 12 months, we can safely say that she's going to have a good outcome in relation to her delivery or in relation to her pregnancy. And folate is one thing which is known to reduce major congenital malformations, like especially neural tube defects and also neural development, because folate also has effect on the developing brain. So the dosage is 0.4 to 4 milligram. We use 4 milligram only when we know that the lady has a higher chance of developing, like patient is on valproate, we know that chances are high. But if she's on lamotrigine, we know her chances are less. So we need not give everybody 4 milligram. So we can give smaller dose, and we should not exceed 5 milligram because it's not useful and it can be detrimental. And another thing that when the lady becomes pregnant, we need to do therapeutic drug monitoring. That is, we need to see whether levels are falling, and we know that lamotrigine and levetiracetam fall significantly. So if we don't have levels, at least if she was on a lower dose, try to increase it by 30 to 50% during the pregnancy. And then we know these drugs, again, the levels start increasing after delivery and can be toxic if they are in a higher dose. So we need to start after 2 weeks or so, we start reducing the drugs to pre-pregnant levels. Now, switching from valproate, supposing patient is on valproate, she's very well controlled, then what do we do? When we have to reduce this drug or switch over the drug, it's a good idea to reduce rather than to switch over, because switching over takes some time and they may not respond as well, especially juvenile myoclonic epilepsies. They may not respond very well to other drugs which are available. So it's better that we give the lower dose and then give her periconceptual folate. And then studies have shown that when the drug is switched over, they have 70% chance of getting seizures. So that is one thing that all of us have to keep in mind, because teratogenicity is less dangerous than the lady having a seizure. She can have, due to seizures itself, she can have major physical injuries. And not only to herself, to the mother, to the fetus also. So folate is a good drug which can reduce the congenital malformation and neurodevelopmental disorders. Now, next is breastfeeding. We all know the benefits of breastfeeding, and we should say that it is safe. In all probabilities, it is safe to breastfeed the child, because all the drugs, except zonisamide, are secreted or penetrated in a very low dose, so that milk is safe enough for the baby to drink. Only when the patient is on phenobarbital or benzodiazepines, we need to see if the baby is sleeping more or becoming drowsy. Now, what is the benefit of breastfeeding? All of you know, it reduces obesity in the child, infections, blood cancers, asthma, sudden infant death. All these are advantages that you can have with breastfeeding. And for the mother also, there is a reduced risk of obesity, diabetes, and breast and ovarian cancer. So please counsel your patients to breastfeed the child. Now, the next is the patient delivers. After that, we need to again, because this is the time when they can have more seizures. So because of poor sleep, they are almost, they don't take care of themselves. They are always occupied with the baby. They have to get up several times, and then they may miss their dose. They may miss their sleep, and that can cause seizures, and injury to the mother can be injurious to the baby also. If she's handling the baby, she can drop the baby. So we need to talk to the patients and their caregivers about safety and good reduction of seizures. And as I told you, very common postpartum depression, about 20%, anxiety, psychosis. It's not just you take care of the patient's seizures, you also take care of her as a this is the holistic medicine. Now, so very important that we counsel starts from premarital, then marital, preconceptual. You don't not only counsel the patient, but her husband and her parents. It's a multidisciplinary team, because the obstetricians, the neurologists, pediatricians, so everybody is involved in this care. So we have to have a regular antenatal care. There should be coordination between the teams. And then we need to evaluate for fetal anomalies like amniocentesis and fetal anomaly scan. We need to keep in mind about therapeutic drug monitoring. And then all I can say is pregnancy is safe when skilled care is provided. So we need to achieve this a happy mother with a baby who's also smiling. So our aim is to see to that the lady is protected all the time and we give adequate care. And I would like to thank all of you for your patient listening.
Thank you, ma'am.
Hello. Thank you very much for your enlightening speech, madam. We came to know obstetricians are thinking about only conversions because of pregnancy induced hypertension. Maximum 90% will be that only. Even in 1 to 10% of the patients will have epilepsy. We won't think about that. Now you have given you have given more knowledge regarding the early conception counseling and folic acid supplement. Already routinely we are doing 1 month prior to the conception, and usually patient will come in labor with the convulsions, will have a lot of dilemmas to treat, will have a little shaky type of decision what to do. That is a main.
Patient has a fit and we have a fit. Yes, ma'am. Hello. Hello, I'm not able to hear.
Maximum patients will come with the convulsions in labor, will have a lot of dilemmas.
Yes.
So what to do? We'll think only about the eclampsia, pregnancy induced hypertension complication. And nowadays we have started with a levetiracetam, levera even IV also, because outcome will be better. Now we have got a knowledge regarding, after your talk, preconception, folic acid supplement already we are doing because of epilepsy counseling. Whether patient had a previously, we can avoid a lot of congenital abnormalities. Thank you for your nice talk, madam.
I was not able to cover preeclampsia and eclampsia because that itself is a different talk. So I just avoided that. And periconceptual folate, at least 3 months before pregnancy, planned pregnancy, she should this thing. But most of the time it so happens they conceive and then they come to us. So we have not much to offer. This is because of our lack of effort from the neurologists to, spread this knowledge in the community about
awareness is not there.
Awareness is not there. We should be held responsible for all this because epilepsy carries so much of stigma. And one more thing that I find is that before marriage, they come and they ask me that what to do. Should we tell the boys' side whether epilepsy has to be revealed? Though epilepsy legally does not stand in the court of law for a divorce, but what happens is that there is a breach of trust. If they don't tell the boy's side that the girl had seizures and they come to know afterwards, then they will file a case. We see so many patients who come here say that so so this is the problem. And they will say, doctor, ನೀವು ಹೇಗೆ ಹೇಳ್ತಿರೋ ಹಾಗೆ ಮಾಡ್ತೀವಿ, ಹೇಗೆ ಹೇಳ್ಬೇಕು ಅಂತ. So I don't know, 1000 ಸುಳ್ಳು ಹೇಳಿ ಮದ್ವೆ ಮಾಡ್ಬೇಕು ಅಂತ ದೊಡ್ಡವ್ರು ಹೇಳ್ತಾರೆ. ಬಟ್ ಈ ತರ ಸುಳ್ಳು ಹೇಳ್ಬೇಕಾ? ಹೇಳಿಲ್ಲ ಅಂದ್ರೆ she'll not get married. For a man it is not difficult. So what I say is, you please bring the boys' side. I will say if the girl is completely seizure free, has no problems, we say that there's no problem in conceiving, marriage, nothing. There's no problem. It's just that 6 to 7% that there will be problems, because what they are worried is that inheritance of mother's epilepsy to the child and teratogenicity. This is what the boy side is worried. So far, no boys, some very few in my practice, boys coming and asking boys' parents, should my son get married because he has epilepsy? Should we tell the, girls' side? This gender inequality is there. But I don't know how to, we don't think about these things, but it's very painful that we come across situations like this where a woman has a problem, they don't tell, and then they stop medication. Soon after the wedding, they come with seizures. So these are all the problems, ma'am.
One more question I have. What is the role of termination of pregnancy when patient is on medication of epilepsy?
No, ma'am, there is no need to do that. If your fetal anomaly scan is normal, if her seizures are controlled, there's no need to do that.
Okay.
There is no need to do, because I told you 90% of the time delivery is successful. Even in general population, we don't say 100% the delivery is going, the pregnancy is going to be successful. You don't say 100%. So here it is 10% chance that the child will develop or she has problems. Mortality is slightly higher. That's why if it is a team approach, and if they have a skilled antenatal care, not just by the obstetricians, but also their drug monitoring is taken care of, I think they have no problems in conceiving. They have all the right to conceive. But if the seizures are not controlled, we say that it's better that they wait.
Okay. Okay. Thank you, madam.
Thank you, sir.
Thank you, ma'am. At the final moral of the story is a girl or a lady with seizures have a normal married life. She can deliver a baby and she can breastfeed her baby also. So there is at least there is no stigma in the medical faculty regarding the pregnancy, breastfeeding. The ladies or the girl can have a normal life with medications and with the seizures. Whatever the course will be there, we will take care of, and she can have a normal pregnancy and deliveries and breastfeeding and all. And regarding the ma'am's that practical questions, there are no answers for that. Recently, I have the same girl with, she is going to marry in the next 3 months. I don't have any answer for her, whether I should tell that guy or not to tell. That somehow we have to manage. I don't know.
Yeah, this one question was asked in our meeting. One of the senior neurologists was asked this question, whether he will marry a girl, if given the chance, he will marry a person with epilepsy. He's a senior most doctor seeing epilepsy right and left. He said, no, I will not marry. So if a learned man says like that, then I don't know what the uneducated person will say. So the problem is this, that's what I was telling, gender inequality, we cannot do anything unless our culture, our society, is more empathetic to, women. I think these problems will always be there. So I tell that get your seizures under control, have a job. You should always have education. You should have a job. You should be economically independent. Then the man automatically marries you.
Thank
you.
You
Don't take it personally. This is what I want to say.
Any questions from audience?
Folic acid preparation is tetrahydrofolate is preferred. Tetrahydrofolate.
Yes, sir. Folate only. Tetrahydrofolate.
And
regular folic acid that we get, folate.
And pre-operative injection in a case of pregnancy with epilepsy, surgeons and anesthetists don't prefer phenobarbital injection because it messes up the respiration. Pre-operative injection in case of pregnancy with epilepsy.
Sir, we have better drugs now. We have levetiracetam available parenterally. We have lacosamide parenterally. And we have brivaracetam, which is available parenterally. So we can use this drug. There's no need to use phenobarbital unless the lady was on phenobarbital already and she comes with a breakthrough seizure, then you can give. Otherwise, there is no need to start phenobarbital in the this thing as a first drug.
Thank you, ma'am. Any more questions?
Thank you, ma'am, for such detailed and wonderful talk.
I hope I didn't exceed time. Anand, did I exceed my time?
I also don't know, ma'am. I have not checked it.
Okay, sorry if I've done that. Thank you very much.
It's a very informative talk, actually, and practical one also.
Thank you very much. I miss coming there in person, but North Karnataka, we are all one, so we remain like that. Thank you very much.
Thank you, ma'am. Thank you.
Thank you, Ashwini, and thank you, ma'am.
Thank you, ma'am.
Thank you very much, ma'am.
Thank you.
Now I request Dr. Sridhar Patil, sir, to to present the memento to the chairperson. Yeah, the memento to the madam will be presented later.
No, Ashwini, thank you. I don't want the plaque. Thank you so much for inviting me and, thank you.
Thank you, ma'am. It was really wonderful. Thank you, ma'am.
Thank you. Thank you, Ashwini. Can I see you, Ashwini? Oh, thank you so much. Thanks.
It was very informative, ma'am. Thank you.
Thank you. Thank you.
Next, I would like to invite consultant, neurologist, BLDE University, Dr. Virupakshappa Birada sir, to talk about status epilepticus. I request the chairperson, senior neurophysician, Dr. Sunil Kallo sir, and Professor, Department of Medicine, Dr. S.M. Birada sir, to chair the session. Over to you, sir.
Good afternoon, all. I'm thankful to the organizers for giving me the opportunity. Now, I introduce Dr. Virupakshappa Biradar. He did his MBBS from Mysore Medical College and DNB Medicine from Malabar Medical College and Research Center, Calicut, and DNB Neurology from Kerala Institute of Medical Sciences, Trivandrum. And sir is actively involved in research and teaching, and he has numerous publications in national and international journals to his credit. Over to you, sir.
Thank you, sir. Thank you, dignitaries. Thank you, teachers. Today's talk, we had a case when I was in resident in second year. One patient by the name Naufia, 24-year-old lady, presented with new onset generalized tonic-clonic seizures. Later, which was turned to be status epilepticus. Later, so we started on lorazepam, then the levetiracetam, then when she went into a refractory, she was on midazolam infusion. Then later, since the seizure was not controlled, we kept on adding the drugs. So we added like phenytoin, then the lamotrigine. Then later, she has to be put on the propofol infusion. Then later, even though the newest perampanel we added, so later we could able to achieve the burst suppression. So even though she was throwing this thing, so we didn't have any other evaluation, including the infective virology and autoimmune virology evaluation was done, was negative. The prophylactically, we thought it could be the autoimmune encephalitis, one of the kind. So we started on IVIG. Then she started showing some improvement. So later, so we could able to extubate and put him on our multiple anti-epileptic drugs. So it was a NORS, it was a new onset refractory status epilepticus. Even though we didn't prove the NMDA receptor encephalitis, but she was responded to IVIG and later she was on follow. So that was a status epilepticus in a case scenario. So International League Against the Epilepsy in 2017 presented with a operational definition. So previously it was like 5 minutes, it was like timings. So that the timings was changed, it made into T1 and T2. T1 is at the time where the usually seizure activity has to be stopped by the time of the 5 minutes. If it is not stopping, there's high probability that the patient is going into the status epilepticus. That is the T1. So that is the where we have to alert and active the generalized tonic-clonic seizures. It is the 5 minutes, and the focal onset with the bilateral tonic-clonic involvement is the 10 minutes. from there it's the second time, that is T2 is the seizure activity keep on continuing without ceasing, without stopping. So then there will be requirement of the IV anti-epileptic as a first line therapy. So the duration was, operational definition of duration was 30 minutes. So for the focal, it was 60 minutes. That was from the ILE classification. So this is it was categorized, the status epilepticus was categorized into stages, stage 1, 2, 3, and 4, where it is divided into early status epilepticus and the established status epilepticus, refractory, super refractory, depending upon if the patient is not responding to the ideal first dose of the anti-epileptics, which we use either in the IV form or the other parenteral way of administration. So this is status epilepticus patient we can encounter anytime, whether in the in-hospital or the outside the hospital. So patient will have the approach to the patient can be the pre-hospital or the in-hospital. So it will be like we will take as in stroke, when is the last seen well, or so if we don't know when the exact onset of the epilepsy and onset of the seizure. So that is when the patient of the last scene was taken as the patient was normal. From there the time will happen. So if we won't interfere in the seizure activity, so it will progress as per the different etiologies. It can progress into the aphasic phase or focal motor, or in the bilateral tonic-clonic movements, or it can be converted into status epilepticus. It can be convulsive, which we can see the generalized tonic-clonic, or it can be non-convulsive. It is called as NCSC, non-convulsive status epilepticus. So we'll be discussing the algorithm. So the status epilepticus can be classified as status epilepticus with the motor phenomena and status epilepticus without the motor phenomena. Status epilepticus with the motor phenomena, as per the ILE classification, as we consider focal onset, generalized onset. So for generalized onset can be tonic-clonic, it can be convulsive, or it can be myoclonic, or it is a focal motor. So again, these can be as per the classification, generalized convulsive or focal onset with the bilateral cerebral hemisphere involvement. So if there is the status epilepticus without motor phenomena, that is called as non-convulsive status epilepticus. So with minimal clinical features and with the help of the EEG, we can make a diagnosis of the non-convulsive status epilepticus, because ideally patient with a status epilepticus after our IV dose of the benzodiazepines or the levetiracetam or with the post-ictal phase, they should recover after a certain amount of time in the consciousness or the improving the GCS. It is not improving. So first and foremost thing which comes to our mind is to roll out the non-convulsive status epilepticus, including the other possibilities like hypoxia or anoxia during that time. So these operational definitions, a time frame was done to avoid the hypoxic brain injury during the convulsive phase in the status epilepticus. So the status epilepticus can be vary with the prevalence is vary according to the age, and it will be the more in the case of the extremes of the age and the different etiologies, and which is having can be a convulsive status epilepticus or can be a status epilepticus which is non-convulsive status epilepticus, that is NCSC. So these are the most common etiologies than which we come across alcohol related low dose of the AEDs or CNS infections. Other than that, when we think about the rare diseases, that is can be remote asymptomatic or alcohol related metabolic, or it can be the autoimmune disorders like autoimmune can be paraneoplastic causes etiology for the status epilepticus. So from the different studies across the globe, there were multiple studies where these population-based studies was defining the etiology, whether the status epilepticus occurring in the background of the history of epilepsy, or it was acute symptomatic, which is happening 24 to 48 hours, or the remote symptomatic, it is more than 1 week of the onset of the acute insult to the CNS in the form of stroke, infection, or anything, or it is progressive, or it can be cryptogenic or the febrile status. There was a landmark study. This was actually published in the NEGM, New England Journal of Medicine. It was an landmark study. Even the ILEA quoted that this trial was done to the main front three anti-convulsant medications to consider these as a drug of choice for the status epilepticus. So in their study, which was given, so a trial using the levetiracetam, that was levetiracetam used in 60 milligram per kg body weight, and the fosphenytoin used in the 20 milligram, phenytoin equivalent per kg body weight, and the valproate in the 40 milligram per kg body weight. So in that study, they found that the after ruling out the possible confounding factors and the matching of the confounders, so they their analysis was there was no superiority, inferiority between these three different class of drugs, which can be used as a which can be used in the treatment of status epilepticus, which has a primary and the secondary outcomes were equal in these subgroups of studies. So, and also there were no much fatality or mortality between each. If it is there, it is almost comparable, and it was due to the secondary risk factors. So what was the algorithm put forward? That was between 0 to 5. So we do stabilize the patient. We'll take care of the airway, breathing, circulation, and so assess the oxygenation. Followed by there will be ECG monitoring to rule out any possible cause for the hypoxic brain injury. If possible, if there is any, you can able to get a JRBS if it is less than 600. So before giving the dextrose, we 60 milligram. Before giving the dextrose, we'll give the thiamine 100 milligram IV stat followed by the dextrose. As you know why we do that. Then followed by, so the drug of choice for the status epilepticus is what we recommend is the intravenous lorazepam 0.1 milligram kg body weight, or the other alternatives are the intramuscular diazepam for either maximum 10 milligram in the body weight more than 40 kg, or the 5 milligram between 13 to 40 single dose, or we can have intravenous diazepam 0.15 to 2 milligram per kg body weight dose, a maximum of 10 milligram per dose. If none of them are available, or none of the above options are not available, if possible, the ideal rectal diazepam, which was used for the febrile seizures also, and are intranasal or the buccal midazolam. So nowadays, if it is a free hospital status epilepticus where you don't have access to the IV testing, so you can consider intranasal or the intrabuccal buccal midazolam dose. So in the next 20 to 40 minutes, so if the patient doesn't if patient continues to seize, so then we have to consider one of these as per the recommendations, the intravenous fosphenytoin 20 milligram per phenytoin equivalents, or intravenous valproic acid 40 milligram per kg body weight. Infuse this has the infusion rates. Okay, phenytoin not more than the 50 to 150 milligram per minute, and the levetiracetam valproic acid also not more than 50 milligram per minute infusions, usually infused over 40 minutes to 1 hour. So, and also intravenous levetiracetam. So what will happen practically, we will use 20 to 40 milligram per kg body weight. Usually we'll load with the 20 milligram per kg body weight levetiracetam, which may one of the reason why the patient, one of the reason out of the, so 76% of the patient may recover, or there will be seizure will be controlled. Rest may continue to seize, go into status epilepticus. So in one of the practical reviews of the data, they found that low dosing of this anticonvulsant. So still practically we may be using the 20 to 40 milligram per kg body weight, which but guidelines recommend 60 milligram per kg body, maximum 4.5 gram per dose, followed by the infusions in the divided doses. So then also if the patient continues to seize, then we have to go for the sedative anesthetics in the next 40 to 60 to avoid the further hypoxic brain injury. So that's what the multiple meta-analysis from the randomized control trials were telling. So use of the valproic acid, phenytoin, diazepam, and phenobarbital, and also lacosamide in the later term. In the benzodiazepine resistant status epilepticus, if the patient continues to seize after even the lorazepam 0.1 milligram per kg body weight, so that is called as benzodiazepine resistant status epilepticus. Then we'll give the one of the first line drugs, valproic acid, phosphonate or the levetrestam. If again they are resistant continuous seize, then we'll call the refractory status epilepticus. So in that study, phenobarbital and the alternative which were not available, alternatives given as a phenobarbital. And phenobarbital was superior to the phenytoin, valproic acid, diazepam, and levetrestam and lacosamide. Why we use only some since levetrestam is considered as a broad spectrum anti-seizure medications. So and also with background of the profile of the patient, we may use, and also the possible etiology while we thinking the giving the whether is a focal onset is a secondary by generalization. So that's also comes in mind, and also underlying the medical and cardiac conditions while administering the lacosamide, be careful. Okay, and so their analysis, the phenobarbital has the greatest probability of achieving status epilepticus control and seizure freedom the 24 hours. So usually we go with the lorazepam, then the levetrestam or the valproic acid, then the sedation with anesthetic sedatives. So while thinking of giving these drugs, so there will be some advantages and disadvantages with the diazepam, lorazepam, midazolam. Diazepam has a rapid onset of action following IV administration, but it has a disadvantage of rapid redistribution, and it causes the short duration of the action, which carries the risk of hypotension and respiratory depression. But if we give in the ideal dose, so there will be lesser chances. Then the lorazepam, which has a rapid onset action following IV administration with a longer effect of more than 24 hours, but we carry the disadvantage of hypotension, respiratory depression, which anticipating the patient goes into respiratory arrest. So ready with the intubation if it is required. The midazolam, as we said, non-IV formulations like buccal, intranasal, and the rectal, IM, even IM diazepam can be used with midazolam. It's a short acting and short action, so risk of recurrence will be more. With the clonazepam, it lacks the randomized control trials, but it has a rapid onset of when it is given the IV. Phenobarbital, so it has a good control over all the other anti-seizure medications, but carrying the there will be significant drug-to-drug interactions with the phenobarbital. So phenytoin and as these three drugs were already studied, they have proven benefit and they have equal efficacy. There is no superiority, inferiority was proven. With lacosamide, which is a rapid action following the IV administration, but the little clinical experience and the lack of control trials and the risk of the cardiac arrest, these patients having the AV blocks should be carefully given. So if that is the convulsive status epilepticus, so when the patient there is no improvement in the GCS, then we have to think of the differential diagnosis of the non-convulsive status epilepticus. So which usually we make a diagnosis non-convulsive status epilepticus by the EEG, continuous EEG monitoring. So which follows the criteria of Salzburg criteria, modified Salzburg criteria, which tells that there is a epileptic form discharges that is 2.5 hertz, more than 2.5 hertz. If it is there in a paper sheet running across this thing, so if it is having the 2 discharges per second between 2 large columns, that is if it is more than 2.5, it is definitely evidence of that status epilepticus. If it is not falling in 2.5, if it is less than 2, so either there will be 3 criteria, whether there should be temporospatial evolution of the this epileptic form discharges, means it started in the one side, then the progressed into the generalized, or there will be delta theta slowing, or if these abnormalities will respond to the IV administration of the benzodiazepines, where we will get the maybe normalization of the background or the attenuation of the background, or we may get the burst suppression. So that indicates the patients in the non-convulsive status epilepticus. And also during this, we can have a clinical, that is nystagmus jerky movements or the fluttering of the eyelids can be seen. If these not follows any one of this thing, it is less than 2.5 or more than 1 hertz per second over the 10 second. To tell a non-convulsive status epilepticus, we should have this feature, that is more than 2.5 hertz per second over the at least 10 seconds to fit into the criteria for the Salzburg criteria. If it is not fitting into the criteria, if with this there can be, there is an entity called as ictal and interictal continuum. So if it is only tells that the EEG criteria, but no clinical improvement after the administration of the anti-seizure medications, still we consider that as a electrical status epilepticus and treat. So this is the nutshell of the clinical diagnosis of the non-convulsive status epilepticus. That may be, it may be the electrical seizure or the electrographic status epilepticus, or the definite clinical correlation with the pattern and the duration. With EEG and the clinical context, we make a diagnosis of the NCSC. So when we call somebody is having the refractory status epilepticus are persisting despite the admission of the at least 2 appropriately selected and the dose parenteral medication, including the one of which should be the benzodiazepines, and there is no specific seizure duration to call it the refractory status epilepticus. So then the entity called as super refractory status epilepticus, so which is persisting for at least 24 hours after the onset of the anesthesia. Once there is a failure of the first line of the anti-seizure medications, we'll go with the anesthetic sedatives like propofol, ketamine, which have their own drawbacks and advantages and disadvantages. Or either without interruption, patient is having the seizures persisting at least 24 hours after the onset of anesthesia, or the either without the interruption or the despite appropriate treatment with the anesthesia. So these anesthesia drugs include midazolam infusion, 0.2 milligram per kg body weight, propofol, phenobarbital, thiopentol, and ketamine. So as soon as the combination of the one benzodiazepine and one anti-seizure medication is failed, that is called as refractory status epilepticus. If it persists for the at least 7 days, that is called as that is prolonged super refractory status epilepticus. If with the infusions of the anesthetic drugs, if the patient is still having to seize for the prolonged 7 days, that is called as prolonged refractory status epilepticus without anesthetics. One entity with anesthetics, another entity. So that is entity which I discussed the first case scenario. That is entity is called as new onset or refractory status epilepticus. It doesn't give any neither specific etiology or the diagnosis, but rather it is a clinical presentation where we get it's like a fever of unknown origin. Fever. It's if you get a NORS, so we have to evaluate for the battery of tests from the commonest to the uncommonest etiologies, from the infective to the non-infective and the autoimmune and the paraneoplastic group of which causes the status epilepticus, which are most common, and autoimmune encephalitis. And that's the entity called as febrile infection related febrile infection related epilepsy syndrome. So it is applicable to the any age and requires prior febrile infection starting between the 2 weeks to 24 hours before the onset of the refractory status epilepticus. Whereas presence of fever at the onset of epileptic season is not the defining criteria. So if I go, it will be elaborative to diagnostic workup for the new onset refractory status epilepticus. So it is to rule out the possible infective etiologies, then the non-infective, initially typical, then the atypical. There is a set of batteries, infective, non-infective, then the autoimmune and the paraneoplastic. So if rare diseases we are considering, we can consider the metabolic, mitochondrial, and the toxicology, which causes the which will causing the status epilepticus, refractory status epilepticus. So that was the assessment at the 24 hours. After the 48 hours, So if the patient continues to have the refractory epilepticus or the coma, so the patient should be considered for the higher therapy. So next next is the high dose of corticosteroids, like 1 gram of methylprednisolone for 5 days, or we can consider IVIG, that is 2 gram per kg body weight over 5 days in a divided doses. If the patient is not controlled with the possible all the different types of anti-seizure medications having the different types of mechanism of actions. So, or we can consider the plasmapheresis. So, if then also if these status seizures are not controlled, we can consider the immunomodulatory immunosuppressive therapies like rituximab and cyclophosphamide. And I can try two of our patient received rituximab controlled, but the other patient which I mentioned, she was better with the IVIG. We stopped, then we are tapering. So we couldn't find out the cause. We made a possible diagnosis of anti-NMDA receptor encephalitis without any EEG evidence of delta brushes. So in the status epilepticus, non-pharmacologically, so what we have mentioned, the surgical interventions like vagus nerve stimulation, which was mentioned earlier, and surgical approaches, and the ketogenic diet. So to brief, so to recall the algorithm for the status epilepticus, we consider to rule out the hypoglycemia, correct hypoglycemia, thiamine and the dextrose. Then drug of choice is IV lorazepam, 0.1 milligram per kg body weight, maximum dose 4 milligram. Okay, or lorazepam or midazolam or the diazepam. Midazolam is 10 milligram IV stat if my weight is more than 40 kg. 5 milligram IV stat if less than 40 kg. Or if it's not available, we can use a phenobarbital. It is 15 milligram per kg body weight. This is if not seizure, then it's called as benzodiazepine resistant. Then the first drug of choice is either of the levetiracetam, phosphonate or the valproic acid, either one of them. Remember levetiracetam in the levetiracetam in the guidelines is 60 milligram per kg body weight loading dose, followed by we can according to the body weight 10 milligram per kg body weight. Okay, but practically we are using 20 to 40 milligram per kg body weight, or the valproic acid and phosphonate can be selected according to the patient's medical history. If it is not, then that 2 drugs failure is called a refractory, then we'll go to the IV sedation with the propofol or midazolam or phenobarbital infusions. So patient should get this thing. Then we have to evaluate for the from the structural, then the CSF, then the atypical causes which are not so atypical. We will cover so many cases. So look for the what are the etiologic workup for the status epilepticus. Thank you.
Thank you, sir.
Thank you, Dr. Irvaksh, for operating on status epilepticus in nutshell. Nice presentation.
Thank you, sir.
I have one question. Sir, is there any role of brevacetàm in status epilepticus? Any latest studies? Any role?
Sir, in
any data?
If a single in the status epilepticus, no role, sir. Levetiracetam, only levetiracetam. So we have the newer drug is parampinor. They will give it's still, even though it is a oral, sir, we'll load with 32 milligram per 32 milligram stat, followed by will reduce to 16 milligram, 8 milligram. Then we'll maintenance dose 4 milligram every day, sir. So it can be given, sir, parampinor. So, but brevacetàm also given for the first attack of the focal onset.
Since relatively it is new drug.
Yes, sir.
So I wanted to ask any
yes, sir.
Any data, any updates?
No, sir. No data regarding the brevacetàm over the levetiracetam, sir. Only if only advantage is levetiracetam carries the neuropsychiatric behaviors, which is not with the brevacetàm, sir. Preferred over the levetiracetam only if the patient is not in the status epilepticus, sir.
Okay. Any questions? Any questions?
Any questions from audience? Can you throw some light on genetics, genes involved in epilepticus?
Yes, sir. So the patient with the genetic disorders, or the patient is who predisposed to the genetic disorder, or the most of the childhood epileptic syndromes are the patients with the neurocutaneous syndromes which having the seizure disorders. But the treatment is not, there is no change in the treatment protocol. Patient presented with the status epilepticus. Patient with the, in one of these studies showing that patient is a known case of epilepsy presented with the status epilepticus. So it goes in the same favors. Since we don't have, if that particular genetic disorder has a gene therapy, so we can consider, sir. Otherwise, the status epilepticus management will be same, sir.
Thank you, Dr. Vipaksh, for nice presentation.
Thank you, sir.
Thank you, sir. I request the chairperson to present the memento to the speaker, Dr. Virupakshapa Birata, sir. Thank you, sir. Now I request Dr. Shravan Kumar, sir, to present the memento to the chairperson.
Thank you, sir. Next topic in the session is head injury and epilepsy. For this, I invite Assistant Professor, Department of Neurosurgery, Dr. Basavaraj Badal, sir. I request Professor, Department of Surgery, Dr. Deepak Chavan, sir, and Associate Professor, Department of Emergency Medicine, Dr. Uday Kumar, sir, to chair the session. Over to you, sir.
Hello. Yeah, a very good afternoon to everyone. Neurosurgeons are the one who spend their professional life in operation theater. So today it's my privilege to introduce the coolest surgeon of BLDE, Dr. Basavaraj Badal, sir. Why coolest? You have to learn certain things from him. The way he counsels the patient, the way he handles the patient, and how cool he'll be in operation theater. I have worked with many neurosurgeons. Either they, yell at us or at the assistants, but I've never seen him doing that. With this, I want to introduce him. Sir has completed his MCH neurosurgery from prestigious university, that is Nizam's Institute of Medical Science, Hyderabad. He has played instrumental role in developing neurosurgical sciences in BLD Institute and has presented many papers at state and international levels. And he has won a gold medal for best paper in TN ESICON 2018. I present to you all Dr. Basavaraj Badal, sir.
Thank you, sir. Thank you very much. And good evening, one and all, and my dear teachers, my colleagues, and my students. Since morning, you know about everything about seizures, its types, presentation, simulology, and treatment also. Now, I just a brief about trauma related to the epilepsy. Here you go. And it can happen in different timing also, as it is in, say that it is in primary impact. At the site of accident, the patient can throw convulsions. There is called a minutes after impact. That one, that is immediate because of contact, or concussive injury, that is called concussive seizures, that is immediate post-traumatic seizures, IPTS. Then seizures occurring patients still suffering from that because less than 1 week, that is called early post-traumatic seizures. It is common, that is occurs in less than 1 week. And seizures occurring more than 1 week after injury because of healing brain producing gliosis, that gliotic part acting as a seizure disorders. That is called a late or remote symptomatic. And it can be said that more than 2 or more unprovoked seizures after 1 week also it is taken as a post-traumatic epilepsy also. And to say post-traumatic epilepsy, patient not having any history of seizures in previous days, before surgery, before trauma. Yeah. So again, seizures itself is a burden. And any head injury patients, we know that their most common population is younger group, a middle age group. Those are getting accidents commonly, and less in extreme ages, because in pediatric and geriatric ages also, even trauma is less, but they are very prone for seizures, all extreme ages. So again, so these are percentage wise as late or early. So we'll go one by one: early, late, and remote one. Reasons for seizures. You know that since morning, you know that whatever maybe, it may be a focal defect, it may be a circuit, means any electric imbalance between the neurons, and any metabolic imbalance also can cause seizures. Here is, we are related with only trauma. Trauma is insult and a latent period because of any trauma, post-trauma patient will have a latent period. Then he developed seizures because of imbalance, metabolic imbalance of the cerebral circulation. Yeah. And we know that any contusions in releases the blood into the subarachnoid space. This will have a hemosiderin, break down the RBCs, that ferric will get deposited on the cerebral. It will act as a seizurogenic. Even hematoma sometimes get calcified in the brain. An early calcification act as a seizure foci. Same thing is a multifocal, same excitatory inhibitory networks involving these things, all you know since morning, whether it is a calcium channel, sodium channel, potassium channel, everything. Any imbalance, these things having a raised electric activity of the neurons producing into the seizures. Something called as a kindling effect. So when you come to the treatment of that post-traumatic seizures, some drugs are anti-epileptogenic or some are anticonvulsants. These things you have to know that what drug to be used when. So these are some example for the anti-epileptic and anticonvulsants. So what the drug we are using, all are not anticonvulsants. Some are just static, just to avoid the seizures. They will not release the anti-epileptic effect of the neurons. So that what you use in our trauma is, we want anti-epileptics, because suddenly that discharge has to be come down immediately, because we know that each seizure will have damage to the more than 10,000 neurons. And in terms, it increases the edema. Already patient having head injury have a raised ICT, is impending. And again, seizures, we don't want seizure in that condition, because one episode of seizures can enough that patient get herniated and he may collapse immediately. So that's why how important of giving a prophylactic epileptic, you'll come to know the little later. The risk, again, any disease you take, some risk factors, factors, everything. Here it is observed that any trauma patients having GCS of less than 10, contused brain, depressor fractures, and subdural hematoma, extradural hematoma, even though it is not direct damage to the brain, but edema can cause seizurogenic activities. And intracerebral hematoma, directly having the brain parenchyma involvement, it will have a seizurogenic activities. And one more, the penetrating head injuries directly injure the parenchyma. Okay, then. Like this is called early. I told you less than 24 hours of head injury causes early post-traumatic seizures. Keep it in mind. And what about the late post-traumatic head injuries causes for post-traumatic? Same thing, if you have a penetrating head injury, at the early onset, patient may not have any seizure activity. Because I told you, as the brain heals with the gliosis, this gliotic part acts as a seizure activity. So most common cause for late PTS is penetrating head injury. That's accounting for more than 50%. And hematoma, I told you that hemocyte didn't get deposit in the parenchyma. It acts as a seizure activity. It accounts for more than 45%. And depressed fractures, again, the fracture fragments will irritate the brain and causes seizures. That is up to 50%. Even early seizures can continue as a late seizures also. It accounts for 26%. Even without having anything, patient having a history of trauma can present with the late seizures in less than 2% of cases. Again, this one, same early going to the late and some other late causes. Again, risk factor for the late one. That's I told you intracerebral hematoma, as it is intradural, extradural. Sometimes what happens intradural hematoma, if his hematoma volume is more, will get operate. Patient will get operate. Even the surgery having other risk of independent risk of getting seizure, because intraoperative you can damage the brain. Intraoperative you can while removing the clot also, the pial tissue has been distorted. Once pial tissue has been distorted, parenchyma get involved. So these are the causes for the late onset of post-traumatic seizures. Now, again, this penetrating head injuries, I told you, it is most commonest cause for the late onset of seizure activities. Accounts for more than 50%. I told you more than that one. And more, this is some data, our Indian data about 2012, 2005, what most causes for the post-traumatic late onset of seizures. And again, the even after more than 5 years also, as previously discussed, that how long is supposed to give anti-epileptic. This thing will go ahead on little later. Even after 5 years also, post-traumatic patients still having a risk of getting seizures in one or the other way. Types, you know that seizure types, as already discussed, this is something different. That is, it's patient may be completely unconscious, seen in more than 75% of the patient. And some focal seizures, we know in casualty also, most of the patient will come with head injury. They will have focal seizures because immediate impact, immediate contusions, any pricking type of injuries at the brain, they will invariably have a focal seizures that invariably will notice at the casualty itself. And again, because temporal and frontal lobe are most common for the getting head injury, because any trauma, any deceleration, acceleration of the brain, as skull stops immediately as you stuck to the object, the brain parenchyma is still moving inside. It will stuck to the frontal and temporal pole. So most of the commonest part of the brain to be injured during trauma is temporal pole and frontal pole. These are more common. Again, these two lobes are more prone for seizures. These things, you know that there is a GDCS. It can cause in non-predating TBI also. I told you, children's, that is more, both the extreme ages are more prone for seizures. Even though sometimes we look CT brain, everything is normal, patients still having a seizures because of edema. A partial is most commonly seen in adults and early. I saw the focal lesions in the CT, is it hematoma, contusion, whatever it is. And penetrating head injury also, because some parenchyma has been involved after dural breach. That part acts as a focal seizures, source for the focal seizures. Other types, we know that it is most of them we will see in working in a department of ER, that is emergency medicine. Patient will come with screaming, shouting, and behavioral changes, everything at the initial impact. That is called this one. And that time it's very difficult to get it easy also, because patient will not cooperate you, because most of them are in under influence. You are not allowing to put a line also. And it is not, don't imagine about taking easy in that patients. So that time what we'll have, we'll have some prophylactic treatment for them. Then how the natural history of the early post-traumatic epilepsy will occur. So see that 50% patients will have a recurrence, only 50%. And 25% have only 2 to 3 seizures in next 5 years, like that. And seizure precipitants, what are the type means, what are the risk factors to get a seizures again in a patient of early post-traumatic head injury? That is sepsis, one thing. Again, it is a getting a prone to seizures. And then hypoxia, we know that head injury patients will have a facial bone fractures, they will aspirate the blood, they will have a bronchospasm, they will go for hypoxia. Again, this hypoxia itself because of seizures. Leave about the primary impact, secondary impact. These are secondary damages. There is hypoxia or hypercarbia. It will again increase the risk of getting seizures as a secondary brain damage. Next comes the metabolic abnormality, that is I told you. Hypoglycemia can occur and hyponatremia. Most common electron imbalance in the ICU is hyponatremia. That itself can cause us as a seizures. Okay. Then again hemorrhage. I told that hemorrhage is this one. Even some antibiotics which are using are very prone to get a seizures like imipenem and quinolones. So we try to avoid initially these two drugs till you confirm that patient not having a seizures like that. And 60% have a precipitants. So 20% of the people in late post-traumatic epilepsy, then what is the natural history means 20% will have a single episode of seizures and will never further occurs, only single episode. And up to 66% have a seizure within first year. And up to 80% will have a very few seizures at the end of second year also, very at the end of second year. And about the half of the 50% of the patients who develop late seizures have 3 or fewer seizures, and they may go spontaneous remission also without having any treatment. So in a late seizures, late onset of seizures, remission over 3 years, 35% will have a seizure free, and 21% will have hardly have more than one episode seizures per week, like that. You know, after 5 years, even after 5 years, having a patient with having a increased traumatic brain injury, that is penetrating head injury, they will prone to have a seizures even after 5 years also. And if you say seizure free, that time you have to evaluate for the seizure free activity of the brain like EEG and other video EEG, everything. In that condition, if you say that patient is seizure free, not only clinically. And again, they will have an increased risk of recurrence, even persistence of partial seizures, seizure frequency within the first year, as I told earlier. Patient will have a combined seizures, and most of the patients, you know, then trauma patient will write after discharge will write medicine for 15 days, ask them to review after 15 days. They will review after 1 month. It means they have left the drug 15 days back only. So this is the most common AED non-compliance in traumatic patients, because patient know that he is a seizure patient, they will take carefully. In trauma patients with that biggest trauma, he told that headache, everything is gone, giddiness has gone, means my have cured. So he will more than 50% patient will come back with stopping drug themselves only. This has to be insisted for them. This drug has to continue as long as I tell you, like that. Again, they will go for the, I told you, trauma patients are, most of them are alcoholic. Once they got recovered, again they will go and again abuse alcohol, they come with other seizures, like that. So seizures begin later after the head injury. So what are the complications of early post-traumatic seizures? As earlier mentioned about, any single episode of seizures activity can damage more than 10,000 neurons in the brain. Like that, it can alter the metabolic rate of the brain, increase the demand, and produce hypoxic damage to the brain. And again, claviosis, again, vicious cycle will keep on continuing. So stopping the seizures is a must in any patient, not only in the trauma patients, like that. So complications of late, I think the next delivery will be about the cognitive, everything will be detailed about your epileptic patient or traumatic patients post head injury or any what psychiatric deficit or psychiatric symptoms will have a challenges in epilepsy. Again, they will consist with the persistent behavioral abnormalities like inhibited behavior, irritability, aggressive behavior, higher incidence of psychiatric related hospitalization in post-traumatic, like that. And functional, patient having penetrating head injury, they will have a definitely cognitive, they will have a hemiparesis, they will have monoparesis. In that, it will affect his employment status also, in terms of family status also. And it may sometimes go into the status epilepticus. One of the reason for status epilepticus is trauma also. And also continuous seizure activity, as told you earlier also, it may end up with the life also. Mortality have been reported in seizures also most of the time. Come to the treatment part. Treatment also has been already explained about, well, what drug to be given, which type of seizures, everything. In brief, what we give and the casualty. Any means you have to select a broad spectrum anti-epileptic. It is safe giving to the pregnant women, non-pregnant women, even elderly, pediatric, everything. All common age group. You used to have a levetiracetam as a drug of choice in right now, because it has act as a broad spectrum anti-epileptic and easy to administer, having a lesser side effect. And what literature says is fosphenytoin or phenytoin is the best to avoid the seizures immediately. Best thing is that in trauma patients, if you give fast any phenytoin very fastly, patient may develop hypotension. We don't want that at that moment. Hypotension is definitely contraindicated any head injury patient initially, because again it produces secondary brain damage. So carefully how to give if you're giving phenytoin. Same thing as already explained about the drugs. So as I told you, what commonly used is levetiracetam, because it is safe to administer, having a lesser complications, easy available as of now. So what should be done for the prophylaxis? Comes to the mind is a drug has to be given to the all trauma patients. How to wait for seizure to occur? Again, it is a debatable question. Some say that no drug can help to prevent the late onset seizures, but at least for the early onset seizures you can give prophylactically. What we suggest is, because early occurs less than 7 days. In that time, patient will be serious. Patient needs more intensive care unit. For that time, we don't want any seizure activity in that period. So what I suggest you is give at least for 7 days, patient not having any seizures. Once patient is fit for discharge, that time you can taper and discontinue and send the patient like that. So what I suggest is any head injury patients, either having a CT finding, not having CT finding, minimal concussion injury also, some altered behavior also, and even brief loss of consciousness also, we will advise to give an anti-epileptic for at least for 7 days. If not having any seizure activity, not having any other secondary brain damage signs, then we can discontinue later on without harming much. And patient having CT findings, that time you have to continue at least for 3 months, like that. Okay, some mild contusions may not produce seizures later also, as literature says, but later seizures are more than 50% can produce later seizures. But keep follow up of the patients, ask him to come after 3 months, like that. Not having any seizure activity, you can repeat the EEG on his OPD basis. If you don't found no activity at the EEG, then you can safely stop the anti-epileptic drugs. So see that no AAD prophylactic can help the patient to preventing late onset, but definitely it can prevent the early onset of seizures. Same thing. Same recommendations for the early and late. Even in pediatric also, we'll recommend fosphenytoin. Fosphenytoin as placebo has been studied, but no much difference between placebo and phenytoin. But what we practice here is we used to give a levetiracetam in pediatric as also. Okay. Same thing, what I explained right now. Surgical treatment, explained everything. If you want to any post-traumatic, any fragments are there, you have to remove the fragments. Contusion is there, causing mass effect, that time you will remove the contusion part of the brain to prevent mass effect, not to prevent the seizures. One thing, in SDH causing mass effect, you remove the brain and evacuate the hematoma. And any calcium means gliotic changes are there in the brain, late onset seizures, you can localize it and remove the gliotic part also. This is surgical part. Patient having a post-traumatic seizures, not the epileptic disorders. Thank you. This will be explained next. Alcohol added this one, cognition, affecting the post-traumatic patients. And adverse effect, you know that everyone explained in previous speaker also, drugs and causing adverse effect. This one, thank you.
Thank you, sir. It was a wonderful explanation by Dr. Bardal, sir. Any questions from audience? Okay, sir, I have a small doubt.
Yes.
What is the duration for late onset post-traumatic epilepsy? Is there any fixed duration to continue the anti-epileptic drugs, or it is based on after a certain amount of duration of treatment, then do a EEG, then for planning for stopping the drugs?
Yeah, as I said, even late onset seizures can occur even after 5 years also. That's what we will tell. If a seizure free period of more than 3 years, then evaluate again, do a EEG. There is no spikes in EEG, you can taper and stop the anti-epileptic after 3 years of seizure free period. After 3 years.
Okay, sir.
Yeah.
Is there any difference of occurrence of seizure in SDH and in subarachnoid hemorrhage post-traumatic?
Definitely, if any focal damage is there, definitely they will produce as a focal onset and then secondary generalization. What upon SDH, most of them having a underlying brain damage. In that condition, seizures will be extensive. In EDH, what will happen? Indirect damage to the brain. They will have a, but seizure is seizure only, whatever they cause. Only they have to initiate the point where seizure activities are there. Maybe it produce as a focal onset, then secondary generalization. Sometimes it produces a primary generalization only. There is no, you cannot hardly you can say only EDH will cause only focal, SDH will cause only generalized, not like that. Any one ignition is enough to produce seizures. Either it may be subdural or extradural.
Okay, sir. Thank you.
Thank you, sir. Thank you
sir.
very much.
Yes, thank you.
Thank you, sir. I request the chairperson to present the memento to the speaker, Dr. Basavaraj Badadal, sir. Thank you, sir. I now request consultant physician Dr. Rajani Durganavar ma'am to present memento to Dr. Deepak Chavan, sir. I also request Dr. Rajani Durganavar ma'am to present memento to Dr. Uday Kumar, sir. Thank you, ma'am. I invite Professor and Head of Department Psychiatry, Dr. Santosh Ramduk, sir, to talk about psychiatric challenge in epilepsy. Now I request Professor, Department of Psychiatry, Dr. S.P. Chaukimat, sir, and Senior Specialist Psychiatry, Civil Hospital, Dr. Nagaraj, sir, to chair the session. Over to you, sir.
I have heard Dr. Santosh Ramdurg in several venues of psychiatry. Let us enjoy what is he going to entertain. Thank you.
Just to give a brief introduction of Dr. Ramesh Santosh Ramdurg. He's my colleague in the department for the last 4 years, an alumni of JNMC Belgaum. He did his post-graduation from AIMS, New Delhi. After that, he had short stints in 2-3 different medical colleges like SDM Dharwad, Demans Dharwad, then a medical college in Kerala. He's there with us for the last 4 years, a very energetic person, extremely interested in research with lots of publications also. And I'm eager to listen to him. Thank you.
So psychiatric challenges in epilepsy. I think all of you heard about thinking out of the box. Have you heard? Let us look into the thinking out of the box. From morning till now, what you have heard, like epilepsy is dangerous and you have to treat the epilepsy. If you do not treat the epilepsy, then neurons will be get damaged, isn't it? So now there is a lot of things between epilepsy and mental health. So let us look into usually my presentation goes in this pattern. These are the 3 people. Who are they? These are the 3 people. They did an experiment saying that inducing an epilepsy is helpful for psychiatry. Isn't it? So if you give a electrical current to the brain and induce a seizure, many of the psychiatrically ill patients, they becomes all right. Isn't it? So these people, they invented electroconvulsive therapy and the things that went on. So that is thinking out of the box. The question is how much you have to induce and how long you have to induce. If you induce too much, then it damages the neurons. Now let us look into what all the psychiatric complications they can happen. But before that, there is a relationship between epilepsy and mental illness has been said by the previous scientists, Hippocrates and other people, saying that epilepsy is equal to insanity and insanity is equal to epilepsy. So now, what are the various theories they're going to affect, like how epilepsy is going to affect the mental illness, or there are 3 things you can see that. One is because of the epilepsy, you treat the epilepsy, the comorbidity will be psychiatric health or mental health. Second, the commonest risk factors, either they can lead to the epilepsy and they lead to the mental illness. Then there is a bidirectional theory, means so epilepsy is going to lead to the mental health and mental illness is going to lead to the epilepsy. These are the 3 theories. And in various aspects of the epilepsy, psychiatric problems, they can happen. You can just see that there is a prodrome, ictal phase, post-ictal and interictal. So in various phases of this cycle, the psychiatric problems, they can happen. So what are those during, as a part of the comorbidity, means like during interictal phase, anxiety disorders can happen, the depression, OCD and other somatoform disorders. And psychopathology is a presenting symptoms of the epileptic seizures. Many times, as a part of the epilepsy, these things can happen like altered awareness, confusion, disorientation, memory problems. So many things they can happen. And also interictal phase, many psychiatric problems, including cognitive dysfunctions, they can happen. Okay. So there are various studies, they say that in epilepsy, many psychiatric problems, they can happen ranging from depression, anxiety, psychosis, personality disorders. And among that, the depression is the very commonest comorbid conditions. So in the group of the studies, they have said the prevalence of the psychiatric problems or depression among these is 24%. You can just see this is a pooled data.
Okay. So what are the various causes for this depression among epilepsies? Learned helplessness, stigma, occupational disruptions, unpredictability, effect on the social life, and poor quality of the life. There are genetic causes, radiological causes, then neurotransmitter changes, all they're going to happen and they lead to the depression. How to treat the depression? The best thing is better control of the seizure is the best way to treat the depression. And second, sometimes some of the anti-epileptic drugs, they can also cause the depression. So during that time, change the anti-epileptics. And several anti-epileptics also have a good mood stabilizing properties like carbamazepine, lamotrigine, and valproate. They themselves going to take care of the depression. And sometimes even in the seizure patient or epilepsy patient, ECT is not a contraindicated. You can use the ECT and it is relatively safe also. What are the precautions you're supposed to take? Start the low dose of any of the antidepressant, like safer antidepressants which are available, and you can start with a low dose and gradually titrate it slowly. Check for paradoxical effect. Check for drug-to-drug interactions. Many times that can happen with anti-epileptics and antidepressant. Monitor the serum concentrations, and sometimes the brain tumor is responsible for both the things, like for causing the seizure as well as for the depression. And sometimes these depressed patients, they tend to take the anti-epileptics in a overdose and it can lead to the more problems. The second most commonest comorbid illness is the psychosis. So psychosis can happen in all the phases, intra-ictal, post-ictal, are a part of the ictal phenomena. So the prevalence is around 6%. The symptoms may be persecutory or referential delusion, grandiose delusion, religious delusions, somatic delusions, or first rank symptoms. They can happen, but they are rare. So this is a pooled analysis. They say that around 6% of them, they're going to have psychosis. So how will you going to treat the various phases? I have already said ictal, post-ictal, peri-ictal, and intra-ictal. What are the differences they are there in terms of the psychosis? The treatment is again treating with anticonvulsant agents, better control of the seizures. Only in interictal phase you can use the antipsychotic agents. Pseudo-seizure, what you call it, sometimes many people they say that they are faking the seizures, but it is not that true. It is a defense mechanism that the brain try to play with when you are in stress. Okay, so it is again patient unknowingly they'll be doing it. It is not knowingly they'll be faking the symptoms. The percent is pseudo seizures or non-epileptic attacks or conversion disorder. This 5 to 10% of the adult patient with pseudo seizures have a comorbid epileptic seizures, and 25 to 40% of the children with pseudo seizures have comorbid epileptic seizures. Means both the things they can happen. In epilepsy, pseudo seizures can happen. In seizures, pseudo seizures can happen. So clinical features will be like very brief or very long-lasting episodes, no self-injury or no tongue bite or incontinence, asynchronous and bizarre movements, pupillary and plantar and other reflexes are preserved, presence of the stressors or emotional trigger, waxing and waning symptoms in the episode, multiple episodes type, minimal post-episode confusion or symptoms, or presence of the secondary gain. So how are you going to identify it? Video EEG and serum prolactin levels. In pseudo seizures, the prolactin levels will be normal. Management is consider the comorbidities, symptoms removal, treat the comorbid conditions, and psychotherapy. Anxiety is also the third most commonest cause in the mental health problems in epilepsy. Suicide, it is quite more common, like 4 to 5 times more common in epilepsy, 25 times more frequently in those with the focal seizures with the altered consciousness. Because of the impaired judgment and poor impulse control, that leads to the suicide. Some anti-epileptics associated with the risk of depressions greater than 1%, like levetiracetam, tiazabine, topiramate, and vigabatrin. These can have more depression and suicidal thoughts, and they may attempt a suicide. So these are some of the commonest risk factors. Cognitive impairment, many times in mentally retarded patient, the seizures are quite common, and the seizures can lead to the cognitive impairment. So this is also one of the things. It's highly debatable topic. Thank you. I know that it's post lunch. Many people they are feeling sleepy. So thank you very much for giving an opportunity.
Thank you, Dr. Santosh, for that brief and enlightening presentation. Any questions from the audience? Okay, thank you. Thank you so much.
Thank you very much, sir.
Thank you, sir. I now request the chairpersons to present the memento to the speaker, Dr. Santosh Ramdog, sir. Thank you, sir. Now I request Dr. Manjunath Masali, sir, to present memento to Dr. S.P. Chaukimat, sir. I also request, sir, to present memento to Dr. Nagaraj, sir.
We'll announce the names now. Please come forward.
With this, we have come to the end of scientific session. We shall commence our much awaited quiz competition.
The quiz teams are Santosh, BT and Sujay from BLDE, Tirish, Noor Fatima and T, Sujay and Santosh, Shubham and Hari from Emergency Medicine, Vinayak and Gayatri.
Oh. That's okay.